Okay, so for today, we'll be discussing about your electrolyte imbalance and what are these electrolyte imbalance that we'll be focusing on. Di ba marami tayong mga electrolytes that was presented before. So today we will be focusing on your sodium, your potassium, and your calcium. And especially we'll be discussing sa last part, we'll be discussing about your magnesium. Okay? Pag sinasabi nating imbalance class, okay, dalawa lang talaga yan when we're talking about your electrolyte imbalances or lahat ng mga imbalances. Okay, there are only two imbalances. If we encounter this word, that means that meron tayong deficit and we also have an excess. Okay, so here's a deficit, hypo yan siya, and here in your excess, that is basically hyper. Kuha natin. So we will just be discussing your sodium, potassium, and your calcium. Okay, now when we're talking about sodium, sino nakagets ng meme na ito kasi ang corny talaga, no? I just place it there, no, just for the sake, no? Sodium natin, you have to make sure kasi wala naman kasing problema sa atin if ever we're going to get the serum electrolytes of our patient. Madali lang yan kasi 'di ba, remember, for every diagnostic examination, for every results that will be given by your or that will be released by your diagnostic examination department, you will be able to see there the normal levels. Okay, so walang problema. It varies as well with the institution kung ano yung ginagamit nila because baka matingala mo nga, uy, di ba 135 over 145 man yung millimolecules per liter ng sodium, tapos pag tingin mo doon iba pa lang, no? Depende din yan sa units class, okay? But with your serum electrolytes, pag ando na yung diagnostic examination natin, the results, you can easily tell if ever it's high or low kasi it is indicated there. Aside from that one, you can have an access to the normal ranges doon sa inyong result. Okay? But for your board examination, most of the time you have to um, memorize talaga ninyo yung range ninyo. Okay? So for your sodium, we have there 135 over 145 millimolecules per liter. Okay, millimole. And this is your extracellular cation. Di ba nga yung sabi ko sa inyo, piso. Okay? Sodium outside. Okay? Tapos if you're going to compare the ratio of your sodium outside or intracellularly and extracellularly, it is inversely proportional with what electrolyte? It is your potassium. Okay? Pag sa labas, if we're talking about the extracellular compartment, mas mataas talaga ang ating sodium kaysa sa potassium. And then for the intra or ICF natin or your intracellular compartment, mas mataas talaga ang potassium compared to your sodium. Okay, maliit lang yung sodium natin doon. Kuha natin. Ayan. So let's talk about your hyponatremia first. When we're talking about the hyponatremia, let's talk about yung ating imbalances or nagkaroon ng problema sa regulatory mechanism of your hormones. One of which is your aldosterone. Okay. Now you have here hypoaldosteronism. That means that there is what decrease ang or there is hyposecretion of your aldosterone. Okay. Ano yung other term for your aldosterone? It's your mineralocorticoids. Okay. Your your hypoaldosteronism. If we could still recall RAAS. Di ba? Remember yung RAAS natin, it involves your aldosterone as well, no? Because yung ating angiotensin 2 would act on your kidney or specifically in your adrenal glands to secrete your aldosterone. Okay? Yung sa ating adrenal cortex. Okay? So once ma-release yung aldosterone natin, what do you think will happen? There will be what? An increase in the reabsorption of your sodium. Okay? So pag ma-reabsorb yung sodium, there will be an increase in the excretion of your potassium then. Because remember, di ba sabi ko, your sodium and your potassium is inversely proportional. So pag meron tayong hypoaldosteronism or there is hyposecretion of your aldosterone, what do you think will happen? Magkakaroon tayo ng hyponatremia. That's one of the cause of your hyponatremia. And now the cause of your or the etiology of your hypoaldosteronism, you have there your diabetes. Bakit tayo nagkakaroon ng hypoaldosteronism when we're talking about your diabetes? Because number one, remember the problem in your diabetes is that there is no or there is absence or lack of insulin, no to little production of your insulin. And when we're talking about your insulin, it is the one that regulates your blood glucose level, no, aside from your glucagon, no. Pag hyperglycemia, lalabas yung insulin natin, no, so that the glucose or the excess glucose in the blood will be utilized by your cells. So papasok yan sila. Okay? Now, ang problema dito is that if your diabetes, or if it is not treated with insulin or with oral anti-diabetics, what do you think will happen? There will be hyperglycemia. Anong mangyayari ngayon kung may hyperglycemia tayo? What do you think will happen to the consistency of your blood? Lalapot siya. Diba? It will become viscous. Now, what happens there is that if ever it's viscous, now your blood vessels, okay, will have a hard time in moving your blood. So, tataas yung arterial pressure natin, or your, your arterial pressure. Pag tumaas yung ating arterial pressure, of course, maapektuhan yung heart natin. Di ba, remember your heart, you have there your atrial natriuretic hormone or peptide. Di ba? What does your ANP does, or what does your ANP do? Di ba? It lowers down your blood pressure, it lowers down your blood volume as well. So ang ginagawa niyan is that there will be an increase, or there will be a secretion of your ANP by your cardiac cells, okay? And then what happens there is that bababa yung blood pressure natin. So remember that your ANP inhibits the release of your aldosterone. Kaya bumababa yung ating aldosterone levels when you are, or when you're having diabetes, or if the patient has diabetes. Kuha natin. Okay, so it is a compensatory mechanism, and the effect would lead to another effect. Okay, for this one, yung ANP natin, it's one of the main reasons bakit bumababa yung ating aldosterone levels. Kuha natin. Now, let's talk about your kidney disease. Pag sinasabi natin kidney disease class, remember, ano yung pumapasok talaga sa utak ninyo when we're talking about hypoaldosteronism? Remember that you have there your renin. Diba? Your kidney is the one secreting your renin. And in your raas pa rin, kung pupunta tayo sa raas natin, you will still, you will know na, okay, kung walang activation or walang secretion of your renin, hindi tayo makakapunta doon, or there will be lesser chances of stimulating the release of your aldosterone. Okay, kasi walang magbabind sa inyong angiotensinogen from the liver, and then from angiotensinogen from the binding of your renin and your angiotensinogen, hindi siya magiging angiotensin 1. Okay? And then of course, mapuputol talaga yung ating yung ating process niyan, or yung activation ng RAAS natin. So because of that one, because of your kidney disease, okay? Kung meron tayong kidney disease, yung function ng kidneys natin will be altered as well. Okay? So it will not function well, it will not release renin, okay? Or konti lang ang ma-release na renin. Thus, okay, hindi masyado makukumpleto yung ating RAAS, or if ever makumpleto man, konti lang ang secretions. That is why we will be having hyposecretion of your aldosterone. Kuha natin. And also you have there your adrenal insufficiency. Pag sinasabi natin adrenal insufficiency, it talks about your what? Adrenal glands. Okay? Yung adrenal glands natin, specifically yung cortex part ng adrenal gland mo, kasi meron yung medulla and you have there your cortex, okay? Maapektuhan ito. Okay, insufficient funds, kulang. Okay, so kulang. So remember that your cortex, your adrenal cortex, is the one secreting your aldosterone. So technically speaking, or logically speaking, kung if you have adrenal insufficiency, then you will be having hyposecretion of your aldosterone. Okay, thus there will no longer be increase in the reabsorption of your sodium. Wala tayong conservation of your sodium yan. Kaya bumababa yung ating sodium levels. Kuha natin. Next is you also have another regulatory mechanism there, that is hypersecretion of your ADH, or your antidiuretic hormone. Sir, tanong, di ba sa ating SIAD, or it's what we call your SIAD, or syndrome of inappropriate antidiuretic hormone secretion, or syndrome of inappropriate secretion of diuretic hormone or antidiuretic hormone, okay? Wala tayong problema sa levels of your sodium. It's just that nagkakaroon ng, if you could still remember, hemodilution. Okay, kaya bumababa yung ating sodium levels kasi nadidilute siya together with the water. Okay, I mean the water is the one diluting sa sobrang dami, or sa sobrang taas ng conservation or reabsorption of your water by your kidneys. Anong mangyayari dyan? Okay, there will be hemodilution of your sodium. Okay, kaya yan siya kumukonte, or that's the reason why bumababa yung ating levels ng ating sodium. And if you could still remember, what would be the hematocrit of this one? Mataas yung ating, not mataas, mababa yung ating hematocrit levels dito. Okay, because of the hemodilution. Okay, nawawala yung solute particles natin. Okay, so you have there, mababa yung ating HCP. These are the common features of your antidiuretic hormone, or hypersecretion of your antidiuretic hormone, which is your SIAD. Okay, hemodilution, that means that there will be decrease in your hematocrit. This, yung hematocrit natin, that is a diagnostic examination, class, ha? Okay? That would confirm as well na nagkakaroon ng hyponatremia. You also have there your hyponatremia not because of the deficit. It is not due, okay, it is not due to the deficit, but basically it is due to your what? Hemodilution. But due to your, hemodilution tayo dyan. And of course, you will have urine concentration. Bakit? Because there is what? Increase reabsorption of water. Okay? Pag sinasabi natin increase reabsorption of water, it does not necessarily mean na wala ka talagang output or urinary output dyan. Okay? There is an increased reabsorption of water and then decreased loss, no, sa output, no, in your urine output. Konti lang yung percentage ng water doon, and here mataas yung excretion of your sodium. Okay? Kaya din tayo nagkakaroon ng hyponatremia. Okay, that's the reason why as well bakit mataas yung ating urine specific gravity. And if you're going to compare the relationship of urine specific gravity to your hematocrit, it is inversely proportional. Kuha natin. Question so far? Okay. Oh. Okay. Yeah. So let's talk about now your hyponatremia. Okay, these are the signs and symptoms of your hyponatremia. Now, remember class, no, pag sinasabi natin hyponatremia, okay, you have to take note of your seizures and coma. Okay, seizures natin, patients with hyponatremia, both your hyper and hyponatremia can lead to your seizures. So dapat you're going to place the patient in seizure precaution. Okay, para aware katong mga, if ever you're going to be done with your shift, ito naman, papasok na naman yung ibang shift, they will be aware na, okay, for seizure precaution, ito siya. Okay, so dapat naka-ready na yung crash cart niya doon, or ninyo doon. Okay, so, sir, paano ba itong seizure precaution? When we're talking about seizure precaution, usually in the hospital, in San Pedro Hospital in particular, what they do there is that they're going to hang a signage or a signboard, no, doon, if ever kung private yun siya na ward or private yun siya na room, ihahang yan nila doon sa doorknob ng patient, or if it's in a general ward, isasabit yan nila doon sa footbar of the bed or doon sa kanilang IV stand, no, to really indicate or to tell the next shift that these patients are may chances na magka-seizure sila. So you have their lethargy as well. Meron din tayong nagkakaroon tayo pag hyponatremia. Nagkakaroon din tayo ng loss of consciousness. Okay, so you have their headache, confusion, apprehension, seizures, and your coma. Okay, so when we're talking about hyponatremia, it is below your normal levels. Okay, so below than or less than 135, and then ito na nga yung sinabi ko, it is caused by your dilution or yung loss natin. Okay, sa dilution wala tayong problema, it's just it's just that your sodium is being diluted. Meron din naman tayong sinasabi na hyponatremic dehydration, if you could still remember. Kung hindi, past is past, no? I-try nyo lang review, no? When we're talking about your hyponatremic dehydration, what do you think is the greater loss there? Yung water na yun or yung sodium? Of course, your sodium. Okay? Pag sinasabi natin hypernatremic dehydration, mas mataas yung loss ng ating water compared to your sodium. Both of them has, pwede silang, yung ating sodium and water doon sa ating hypernatremic, okay, both of them there's loss. Pero mas mataas yung loss ng ating water. That's why mataas yung ating sodium levels. Okay? Yung sa ating hypernatremic dehydration or your hyperosmolar dehydration. Okay? And for your isoosmolar naman, both of your sodium and water equal ang loss niya. Okay? So what are the causes or the etiology of your hyponatremia aside doon sa ating hyposecretion of your aldosterone and hypersecretion of your antidiuretic hormone? Ito. You have there your gastric suctioning, okay, or yung gastric lavage natin. Okay? You also have there your diarrhea, vomiting. You also have there your diuretics because remember your diuretics, pinapaihi niya ito. Okay? You also have there your mannitol, which is a hypertonic and at the same time a diuretic as well. And of course, inadequate salt intake, no, yung ating sodium chloride. Okay, so these are the etiology of your hyponatremia. Kuha natin. Ayan. So dili pud siya okay nga dili ka tigkaon og food that is rich in sodium natin. Okay, tama-tama lang, di lang pud ta sige kaon og kanang high salt content. Okay, kay magka-hypernatremia man pud ta na, and then you will be having their hypertension. Okay, kasi naman tay fluid or water retention once we do that one. So for the medical management, okay, ito na yung sasabi ko sa inyo, hypervolemia or isovolemia, fluid restrictions tayo dyan. Okay, and then oral sodium supplements tayo. And then you also have their hyponatremia, give isotonic IV solutions or your normal saline solution for your hyponatremia. Okay? And offer high sodium food. Kasi nga dito mababa talaga yung ating sodium levels. Dito naman, okay, anong tawag? Merong loss pa rin sa ating hypervolemia. May loss pa naman sa ating sodium. Okay? And in severe cases, infusion of hypertonic saline solution, pag mababa na talaga masyado, no? If the case of your hyponatremia is severe, saline solution talaga niyan. Okay? If hyponatremia is brought about by your sodium deficiency, plain NSS tayo. Okay? But if ever dili naman, of course, we will be treating yung, let's say for example, ano bang example na hindi siya deficit? Of course, yung sayad natin kanina. Ang ating unang ititreat dyan, or we are expecting the primary healthcare providers, which are your doctors, to treat yung ating sayad muna. Okay? Because yan, siya man yung nagpapalower ng ating, ano tawag ito, sodium natin, sodium contents natin. Okay? Ayan. Now, for your hyponatremia, these are your nursing management vital signs tayo. Okay? Especially your blood pressure and your pulse. Okay? Kasi usually, dehydration yan siya. You will be having their pag isotonic or isovolemic or isonatremic dehydration, no? Bumababa yung ating blood pressure. Aside from that one, yung ating hypotonic. Okay? Sir, sa hypertonic, hypertonic dehydration, bumababa din ba? Yes, of course. Bumababa siya. It's because of the fact that there is a greater loss of fluid in our body. And remember that water is 60% of your body. No, tira-tira lang doon is mga sodium doon. Kaya bumababa din ating blood pressure niyan. Watch out for orthostatic, ayan na nga hypotension, and of course tachycardia. Your tachycardia is brought about by your compensatory mechanism. Kasi low blood volume tayo dito eh. Okay? Monitor neurologic status, yes, neurologic status tayo yan. NVS tayo. Okay? Report any deterioration in level of consciousness, and again, seizure precaution. Okay? Accurately measure INO natin, and then assess skin turgor. Okay? Hydration rounds tayo. No, doon sa inyong anong tawag ito? Sa inyong RLE, di ba? During endorsement, sasabihan kayo hydration rounds every 4 hours. That means that you are assessing, or that you will be assessing, okay, any signs or I'm sorry, yes, signs of dehydration. Okay? You check for the capillary refill time, you check for the skin turgor, you check for the periorbital region if there is sunkenness. Okay, kung newborn yan siya, you check for you're going to palpate for the fontanelle of the newborn kung wala pa nag-close, no? Kasi kung dehydrated yan, you will be having depressed fontanelle. Okay, pag overly hydrated yan siya, or there is volume or fluid volume excess, there will be bulging of your fontanelles. Okay, ayan, skin turgor tayo dito. Restrict fluid intake as ordered is the primary treatment for your delusional hyponatremia, because nga, remember that wala tayong problema sa ating sodium. It's just that because of the too much retention of your fluid, nadidilute yan siya. Kaya there is still fluid or restriction of your fluid intake. Depende talaga yan siya sa case ng patient natin. Okay? It does not necessarily mean pag hyponatremia ka, bigay mo kagad ng IV solutions na na hypertonic. Okay, no. Because remember, kung maka-remember pa talaga kayo, no, you have there, di ba, yung hypernatremic dehydration. Okay? Meron din tayong hyponatremic dehydration. And you also have there your isonatremic, dehydration. Kuha natin. Ayan. And the hematocrit in each of these dehydration will vary as well. Kuha natin. Pag hypernatremia na tayo or hypernatremic tayo, your hematocrit is increased. Hyponatremia tayo, your hematocrit is decreased. Okay? Isonatremic, within the normal levels lang yan siya. Okay? Or if ever severe yung kanyang both your sodium and water loss, okay, tataas talaga yung ating kuan, yung ating hematocrit din. Kuha natin. Ayan. So you have to administer as well your oral sodium supplements. Kung ano yung cause or kung ano yung kulang talaga for your hyponatremia, since sodium ang kulang dun, if there's deficit for that one, okay, not because of the hemodilution, bigay ka ng oral supplements for your sodium. Okay, provide safe environment for patients with altered thought process. Kasi nga, aside from that one, nagkakaroon sila ng seizure. Okay, seizure precautions tayo. Next, okay, yung kabaliktaran ng ating hyponatremia. We have there your hypernatremia. Okay, it is above the normal range natin, 135 to 145 yung ating millimole per liter. Okay, so etiology, we have their hyposecretion of ADH, which is your diabetes insipidus. Kung doon sa taas sa ating hyponatremia, okay, it is your SIAD. Okay, ang counterpart niyan is the hyposecretion of your ADH, which is your diabetes insipidus or your DI. Okay, most of the time it is idiopathic, but pag sinasabi natin antidiuretic hormone or your vasopressin, okay, it is located in your, or it is secreted in your, or by your pituitary gland. So any patients who underwent head surgery or head injury or head trauma, or trauma, okay, maapektuhan yung brain natin. Most likely, maapektuhan yung ating pituitary gland. That's why nagkakaroon tayo ng hyposecretion of your antidiuretic hormone. Okay? Now, there are three common features compared or katulad na lang din ng inyong hypersecretion of ADH, which is your SIAD. Meron din siyang three common features. If you're going to create a table on that one, kung doon sa ating SIAD meron tayong hemodilution, dito magkakaroon tayo ng hemoconcentration. So nagkakaroon tayo ng mataas na hematocrit levels tayo dyan. Kasi nga mas mataas na ngayon yung ating mga solute contents, okay, sa ating blood. Okay? You also have their hypernatremia due to hemoconcentration, and urine dilution naman. That means that mababa yung ating specific gravity. Bakit sir magkakaroon ng urine dilution? We're talking about your hyposecretion of your antidiuretic hormone. So sige ka ihi, ana, sige ka ihi, sige ka ihi. And there will be a compensatory mechanism of the body to regulate your sodium. Okay, there will be conservation of your sodium, pero sige ra gyapon kag ihi ug water. So there will be increased water loss. Okay, compared to your sodium. Okay, kaya yan siya diluted. Wala ka masyadong makikita particles or solutes doon sa ihi mo or sa urine output ng patient natin. And that's the reason why mababa yung ating urine specific gravity. Again, the relationship of your specific gravity to your hematocrit is inversely proportional. Okay? Manifestations, you have your polyuria and polydipsia. Sir, diabetes insipidus, is it somehow related to your diabetes? When it comes to etiology, no, dili. No, dili. We don't have any problems with the insulin here in your diabetes insipidus. Ang problema dito is yung ADH natin or yung antidiuretic hormone mo. There is hyposecretion. Okay? That is why it's called diabetes insipidus. It's because of the fact that you have here your polyuria and polydipsia. Remember that in your diabetes or yung DM natin, may it be type 1 or type 2, they have three P's there. Your polyuria, polydipsia, and the third one is your polyphagia. When we say polyphagia, this is extreme hunger of the person. If we talk about the cellular level, this is now the extreme hunger of your cells. Kuha natin. Itong polydipsia, this is extreme thirst. Okay? Muna sige siya inom og tubig kay because there is continuous fluid loss naman tayo dito sa ating diabetes insipidus. Okay? Kaya sige na siya inom. And then polyuria because there is frequent urination. Ayan, that's the reason why bakit siya tinatawag na diabetes insipidus, no? Yung word na diabetes. Now, for your hypernatremia, this is what you have to remember about your hypernatremia, okay? Causes of your increased serum sodium, we have there your medications or meals that there's too much sodium intake. No, sa ating MO for osmotic diuretics. That means that there will be an increase now. Pag sinabi natin osmotic diuretics, itong mga osmotic diuretics natin, they increase the excretion of your, anong tawag ito, yung potassium natin. But of course, there will be retention of your sodium. Okay? You also have there your diabetes insipidus. Yes, na discuss ko na ito. Excessive water loss. Yes, due to your diabetes insipidus. Pwede, no? Pwede. And of course, you have their low water intake. Okay, kung mababa lang yung kuan mo. Let's say, for example, kung old ka na, remember that your thirst regulation declines as well as we grow older. So mga elderly natin, they are at risk for hypernatremia. Kuha natin. Ayan. So this is now one of the ways not to remember your hypernatremia then. Okay? With the management as well. So you read this one. Same pa rin yun, no? Same pa rin ito yung thought. You have there your thirst regulation there as well. Okay? Pag mataas yung ating hyper or pag mataas yung ating sodium levels in our body, of course, gagana yung ating thirst regulation natin. No? Doon sa ating hypothalamus. Okay? Ayan. So you also have there yung antidiuretic hormone dito. Okay. Next, for the manifestations of your hypernatremia, the thirst talaga. Ito pinakauna for the manifestation. Kasi 'di ba, remember that if there will be an imbalance of your fluid and your solutes, no, let's say for example, kung how do you call this, kung mataas yung sodium content natin, kung mataas yung glucose content natin, ayan, okay, it will tell us to drink talaga, no, the thirst manifestation. Okay. And then lethargy, if ever thirst is not relieved, let's say for example, wala jud kay resources dira nga makainom kag tubig, okay, or na kay oral trauma tapos wala ka na hook sa IV, it's because of the fact nga siguro na stranded ka, wala pa ka nadala sa ER, it will now create your altered neurologic function. So nagkakaroon tayo ng lethargy. Okay, hindi ka na siya, or you will not be easily stimulated. Okay, katulgon ra jud ka na. You have there your weakness, irritability, and can progress to seizures, coma, death, and death in severe death and severe hypernatremia. Okay? Ayan. You also have there your low-grade fever kasi nga meron tayong hypernatremic dehydration, di ba? Hypernatremic dehydration, you also have your flushed skin, dry mucous membranes, oliguria, and also as well orthostatic hypotension. Okay? But if hypernatremia causes your increase in your blood volume or water retention, then that means that aside from your orthostatic hypotension, magkakaroon din tayo ng hypertension. Okay, pag mataas yung ating blood volume at the same time mataas yung ating sodium contents. Okay? Yan. Next, for the medical management, you have their treatment for hypernatremia varies with the cause. Di ba? Remember nga natin, meron tayong hyponatremia, or we have their different losses of your sodium and water. Okay, so that depends on kung sino doon ang mas mataas na nawawala or mas mataas yung losses natin. That means doon magva-vary yung ating management. Okay, the underlying disorder must be corrected and serum sodium levels and related diagnostic tests must be monitored as well. Note that the fluids should be given gradually over 48 hours to avoid shifting of fluid into the brain cells. Pag mag-shift kasi ang fluid natin, okay, pag nabigla yung pagbigay natin, okay, hindi siya gradual. Okay, ang mangyayari dyan is that it will shift, no, fluids natin from the intravascular going to your interstitial na naman. But we are talking about sa cerebral part, no, sa ating brain natin ngayon. Okay, so magsiswell yung brain natin, so magkakaroon tayo ng increase in your intracranial pressure. And that would also contribute to your altered level of or altered level of consciousness. Okay, so masamutan pa ang patient, ana. Kuha natin. Ayan. So nursing management, yes, IVF fluid replacement. So meron tayong D5 water to return sodium levels to normal. And then you also have there your sodium intake restrictions. Kasi hypernatremia tayo eh. Hypernatremia. So restrictions tayo sa sodium, not sa water, but sa sodium content natin. Administer diuretics to increase sodium loss. Yes. Monitor the record vital signs, especially blood pressure and pulse, because nga it can cause either hypotension and hypertension. No? Magkakaroon kayo ng hypostatic or orthostatic hypotension. Okay? And again, depending kung ano yung loss natin. If ever you have hypernatremia plus increase in blood volume, okay, mataas ang blood pressure ng patient natin. Okay? Check neurologic status frequently, NVS tayo. Report any deterioration in the level of consciousness. That is the effect of checking or monitoring your neurologic status. Careful measure and record intake and output. Yes, no? You're now going to check kung tumataas ba yung urinary output ng patient natin. Okay? And of course, aside from that one, mag-submit ka man yan ng specimen doon sa laboratory to check for the specific gravity and for the specific gravity nga of the urine. Okay? Ayan. Monitor serum sodium level and report any increase. Yes, assist with oral hygiene. Bakit nagkakaroon assisting in oral hygiene? If the cause of your hypernatremia is dehydration. No, kung mas marami yung water loss natin. Of course, mas fragile na ang ating mga mucous membranes for that matter. Provide a safe environment for confused or agitated patients. Okay? So restraints, pwede ba? Hindi. No, you don't put restraints on the patient unless na lang if of course they're going to sign a consent. No, kailangan talaga ng consent ang restraints natin. So you just have here your picture, a picture of your anong tawag ito? Addison's disease. This is an example of your adrenal insufficiency. Pag sinasabi natin Addison's disease, guys, it is basically mababa yung ating cortisol and release of your aldosterone. Okay, so nagkakaroon tayo ng hyposecretion of your aldosterone and hyposecretion of your cortisol. So ito yung nagiging itsura ng patient natin. Okay, for your Addison's disease. Okay, and then aside from, pag sinasabi kong hypoaldosteronism, that means that there will be hyponatremia. Pag hyperaldosteronism, remember that na-activate na talaga yung RAAS natin dito, then there will be sodium retention. Kaya tataas yung ating sodium levels. Okay? So pag decrease ang ating sodium, there will be hypotension and hyponatremia. Okay? Pag decrease ang ating potassium levels, hypertension and hypokalemia will follow, and low plasma renin din tayo dyan. Yan. Okay? Questions before we go to your potassium? Questions? Napasig nagkuha na mo, anak. Naglisod mo. Any questions? Wala? Sure, hindi ma-process ng utak. Sige. Ayan. Potassium tayo. So for your potassium, remember this level 3.5 to 5 milliequivalents per liter. It is what? Your intracellular cation. It is the most abundant intracellular cation because of your PSO, no? Potassium inside. Okay. Now, pag sinasabi natin potassium class, ito na. It is directly proportional to your impulse transmission. That means that if you have hyperkalemia, mataas ang impulse transmission natin dyan. Okay, what do you mean by impulse transmission? Kanang mga impulses natin that is coming from our sensory, okay, from our sensory receptors, okay, papunta sa ating brain, and then from the brain going to the effector natin. Okay, so yan yung siya yung mga impulses natin. No? Kung mabilis or kung mataas ang ating calcium levels, mabilis ang ating impulse transmission. That is why, ito yung mga manifestation. Mabilis yung impulses natin. That means that mabilis yung ating peristaltic movement doon sa ating GI tract. Sa GI tract natin, ha, you will have there diarrhea kasi mabilis yung ating peristaltic movement. Magkakaroon tayo ng tachycardia din because there is increase in impulse transmission, and you also have there your intestinal colic. What do we mean by intestinal colic? Pag sinasabi natin intestinal colic, this is basically abdominal pain or pain in the abdomen. Okay? Kaya diba, sige kag muscle cramps ana, no, because of due to muscle cramps. Okay? Aside from your anus getting mahapde, kay sige magkag diarrhea ana or sige magkalibanga o sige gawas niya, tubig gawas. What happens there is that of course your muscles will contract as yung abdominal muscles natin. So it will frequently contract kaya nagkakaroon tayo ng intestinal colic. Okay? Pag mababa naman yung ating potassium, that means that hypokalemia, there will be decrease in the impulse transmission. So it is the complete opposite of the manifestation of your hyperkalemia. Okay? Kung dito tachycardia, bradycardic tayo dyan. Okay? Kung dito mabilis masyado yung movement ng ating or active masyado yung bowel movement natin, dito magkakaroon tayo ng paralytic ileus. Sir, tanong, what do we or ano ba yung paralytic ileus? So sa sobrang slow ng ating bowel movement doon, hindi na gumagalaw. There's like less to no movement of your bowel. Okay? So mahina masyado or mabagal masyado yung peristaltic movement natin. That is why if you're going to talk about paralytic ileus, what do you think? Anong magiging, anong say mahitabo sa inyong tae? What will you experience?
Hard, guys.
Hard. O, unsa man na siya nga hard? What do we term that one? Kung hard kay mong tae. Unsa gani ito? Constipation. If here meron tayong diarrhea, kasi sobrang bilis ng ating bowel movement dito, mabagal yung ating bowel movement, then of course, you will be having constipation. Okay, in some books, magkakaroon din tayo ng intestinal colic. So both of your hyperkalemia and hypokalemia, magkakaroon ka ng intestinal colic dyan. Okay? Now, ito yung mga bagay-bagay na mataas ang potassium levels or that is very common in your board examination. Okay? So you have here PABOs na tawag mnemonics for that one. So you have there P for potato, A for apricot. Okay? Mo lang ni siyang picture kay kabalo na ko unsay kabalo ko nga kabalo mo unsay naong sa patatas, sa banana, sa orange, sa watermelon ug sa strawberries. Ang apricot wala siguro most of you or some of you doesn't know or don't know kung say naong ang apricot, mao ni siyang apricot. Okay? I don't know what pag siguro ko kaun ana. Ambot murag dili siguro na uso diri sa Pinas. Okay? I don't know what an apricot is. Anyways, pag sinasabi natin potassium class, you have here food that are rich in or that is rich in potassium. Now, you have your potato. No? As you go down along this list, bumababa yung potassium levels natin or bumababa yung potassium content ng food na ito. So on the list, if in your board examination, you will be asked kung saan dito yung may pinakamataas na potassium content, it is basically your potato. Okay? Ang least naman is of course your strawberries. Kuha natin. So these are the food that you need. No? Sir, ang sutong mong ingon nga katong green leafy vegetables, yes, pwede gyapon kay taas man gyapon to siya og kwan. Potassium content. No, nagyapon to siya potassium content. So pwede gyapon to siya ma-appeal. Okay? Ayan. So the etiology of your hypokalemia, that is basically inadequate potassium intake sa diet. Okay, dietary intake tayo. Mababa yung or insufficient yung dietary intake natin ng ating potassium. Severe GI losses such as your suction, GI suctioning, GI lavage. I'm going to show you a picture of that one later. You also have there your prolonged vomiting can deplete the body's potassium supply. As a result, potassium levels drop, and you also have their drug associated such as your diuretics. Etong thiazides and furosemides, di ba? Your diuretics can either just be your potassium sparing and your potassium wasting. Etong thiazides, this is a specific classification, drug classification of your diuretic, and you also have there your furosemides. Ito yung furosemide, this is a drug already, a solution. What is the classification? If this is your thiazide, this is your loop diuretics. Okay, loop diuretics tayo dyan. You also have there your corticosteroid and you also have there your insulin. Okay? Kasi remember, di ba? Balik tayo sa insulin natin. This is also important to know the concept of your insulin sa ating fluids and electrolytes kasi pupunta tayo sa ating renal failure mamaya. Okay? Or not really mamaya, no? In the next few days. Now, remember that your insulin acts like a key. Okay? Susi yan siya. And the other hand, di ba, molecule man yan siya. And of course, you have your cell. And remember that your cell has receptor sites din. Na doon mag-bind yung ating insulin. The molecule insulin will bind to that receptor site para mabukas. No, para magkaroon ng gateway. No, para mabuksan yung door for your what? Glucose. And you also have there your potassium. Okay? Now, pag ang isang tao may diabetes, okay, may diabetes yan siya. And remember, wala kang problema sa potassium levels mo. Ha? Pag may diabetes ka dyan, ang ratio ng ating glucose compared to your potassium, mas mataas ito eh. Kasi ito, normal lang ito eh. And remember that if ever you have here your insulin, it will always carry yung potassium natin and your glucose by pair. Now, logically thinking, kung iisipin nyo, i-analyze nyo, hala, bitaw, no? So, if ever normal numbers lang yung kanyang potassium, okay, makulangan jud siya. Okay? So, pagpasok ng, or once your insulin, this is your insulin, okay, once your insulin binds into your receptor sites, papasok yung dalawa as a pair. Kaya kailangan ninyo, the reason for or anong tawag nito, pag meron kang, how do you call this, hyperkalemia, no? If we go to your hyperkalemia, okay, and also you have there your glucose, ha? Okay, kaya ka nagkakaroon ng hyponatremia, ito yung explanation, okay? Pero pag ikaw meron kang hyperkalemia, the ratio of that one is mas mataas talaga yung glucose compared to your normal levels of your glucose. Okay? And the treatment for this one is that D50 water plus your insulin. Oh, sorry, 1L lang insulin. Okay? Sir, paano pala ma-normalize ang ratio ng ng potassium levels mo compared to your glucose? Ito na 'yun. Ito na yung answer. Remember, D means dextrose. Okay? From the word itself, no, dextrose. Na siya glucose na mga rose na to kana mga sucrose, fructose kana mga os na to. That is basically glucose or form of your sugar. Okay? That's the reason why we are trying to induce hyperglycemia to the patient na merong hyperkalemia. Kuha natin ang logic bakit bumibigay tayo ng D50 water wherein this type of solution, marami ang kanyang glucose levels or glucose content. Okay? And you also have your insulin. Para once magpasok or once you have given the insulin, okay, merong pair talaga yung ating glucose and your potassium. Okay? Para ma-facilitate yung pasok ng potassium and glucose ninyo doon sa cell natin. Kuha natin. So dito, of course, if ever you have hypokalemia, okay, patataasan natin yung ating potassium levels. Okay, if ever you're going to give insulin, okay, to the patient with DM. Okay, kuha natin. Questions? Wala ba? Okay. Inani ni klasa, na-observe lang na ako ba? African students, no, specifically your Nigerian students compared to Filipino students. Okay. Ang isa ka slide na ko, class, siguro inani, ang content. Inani na ng content, it will take like 1 hour for me to finish. Okay, after na ako mahuman, mangutan ako nga, okay, are there any questions? Sala, grabe sila mo raise of hand because they want to repeat it. No? Okay, ginasulat yun na nila. It's either ganito yan ang analogy or the logic there. It's either you grabe ka bright sa mga Pinoy nga students, okay? Or sa tawag ana ay maulaw lang jud sila, mangutana. Ito class kapoy kay mugstorya didto. Sir, no? Any questions? Ako na lang mahadlok mangutana. Are there any questions? Ako na lang jud mahadlok. When I see that the time is hapit na mahuman and then there's just a lot of things to explain, di na jud ko mangutana ana. Are there any questions? Dire kay grabe. No? So nalang sa duha. So I think asa man mo sa duha? Sa first no. Feel na ko no. Mga smart yun yung mga Pinoy. Okay? Ayan. And this is your gastric lavage. Okay? So for your gastric lavage, di ba ang problem natin is hyponatremia. Okay? What do you do with your gastric lavage? Your gastric lavage is just like another term for your gastric suctioning. Okay? So magpa-flushing ka dyan because maybe there is poison na atong pasyente. Okay? So mag-plain NSS ka dyan na solution, no, for your lavage, no? Lavage ba kanang lava, no, kanang ginalimpyuhan, no? So magpasok yan sa dyan. Okay, once it is full, you're then going to anong tawag ito? You're going then to drain that one. So papasok mo yung plain NSS solution or your normal saline solution, papasok yan siya dyan. And then after a couple of minutes, i-drain mo yan siya. That is basically gastric lavage. You're going to empty the contents of your stomach. Okay, kasi nga na poison eh. Okay, kuha natin. Ayan. So your potassium deficit, you have there the manifestations, you have there your alkalosis. Remember niyo yung class ha, di ba sa lecture, if ever you have viewed the lecture sa asynchronous, okay, you have there your potassium pag mataas and pag mababa. Pag mataas ang ating potassium levels, magkakaroon ka ng acidosis. Okay? Pag mababa naman yung potassium natin, alkalosis yun siya, syempre. Kuha natin. Okay? Ano ulit yung ating treatment regimen or treatment management for your potassium? D50 water. D50 water plus insulin. Okay? Common question jud na siya ginapa-explain sa inyo na sa 4th year during your ICU rotation. Okay? Okay, you have there your shallow respirations as well. Irritability, confusion, weakness, fatigue, lethargy, thready pulse, and decreased intestinal motility. So you have there your nausea, vomiting, and your ileus paralytic na siya. Paralytic ileus. Okay? Kaya tingnan niyo sa picture na ito, ayan, you have there natutulog yung kanyang intestinal tract. That is why most of the time nagkakaroon ka ng constipation and may times din na magkakaroon ka ng intestinal colic or pain no, doon sa inyong abdomen. Okay? Okay to. Hi, mali to class, hindi to siya na-trimia. Wala ako na-edit. Hypokalemia na siya. Nalapod ko. Okay. Isa pa ito. Kana. Okay. Now, for your hypokalemia, this is also important in your board examinations. Yung ECG abnormalities natin. Now, I will not be discussing to you yung ECG ninyo. No, I'm not the proper clinical instructor to instruct you or to teach you with your ECG because that's not my cup of tea. No, hinay yun kayo kuha ng ECG. Okay, the only thing that I can give you right now is the picture or the pictures of how it will look like. Okay, now this is your normal ECG. Okay, normal ECG natin, that means that normal din yung potassium levels natin. Okay, so you have there your P wave, your QRS complex, and then you have there your T wave. And my times class merong shallow na U wave for normal, and there are times when flat lang din siya. Okay? And then after this one, magkuha na tayo. P wave na naman tayo. P wave, QRS, and then, okay, ano na siya for your normal. May times talaga na yung U wave natin, hindi yan siya nakikita sa ating normal. Okay? Normal ECG tracings natin. Okay, what do you have to remember? UST. Remember the acronym or the mnemonics of the UST. Presence of U wave, meron talaga. This is classic ECG tracing in your hypokalemia. Another one is your ST segment depression. Sir, ano bang mukha ng ST segment depression? You have here, dito tayo, ST segment kasi ito. Okay? Now, you have here a depression. In a normal, if you're going to compare it to your normal ECG, flat lang talaga yan siya. Okay? Dito may depression. And lastly, you have there your inverted T wave. Okay? Or your T wave is flat or inverted. Okay? So you have there, sir, asang T wave dira. Okay, you have there your shallow T wave or meron din ito siyang, kung hypokalemia tayo, kung inverted ating sinasabi, if this is your T wave, muana na siya dire class. Okay? Dili ni siya mao, aside from your shallow T wave or ano na siya. Kuha natin. That is what it means by your inverted T wave. Okay, wala dahi gipakita dire ang inverted. Okay? Ang gipakita lang dire ang shallow, but for your inverted T wave after the ST depression, samot pa jud siya bunaog dira. Okay, that will now be your inverted T wave. Kuha natin. Ayan. For your hypokalemia medical management, of course, kulang tayo ng potassium, we're going to give potassium. And yung pinaka-common talaga, oral supplement is your kalium durul. Okay, this can cause gastric irritant or can cause gastric irritation. Okay, so if ever this is, no, isipin mo, if you're going to take any medications, let's not talk about kalium durul, pero we will be talking about gastric irritation. Ano ba to? Are you going to give it with meals or without meals?
With, sir.
Yes, exactly. With meals tayo. Very good. So with meals talaga tayo dyan, class, ha? Basta gastric irritant. Okay, so if ever you're going to give kalium durul, one of your nursing responsibilities is that you're going to give it with meals or together with meals. Okay, or maybe after meals agad. Okay, may po na ninyo pabutig hours, no, before you give it. Okay. And then you have here your potassium chloride kani pampapatay pud ni, no, your KCl. Kung naamoy gusto patyon, no, pag palit mo dito KCl, perting taasa. Okay, tapos tunggabon niyo sa neck, namamatay matiurok ang inyong kuan ana, yung kalaban. So the max dose of your KCl is 10 to 15 equivalents per hour. No, per hour yan siya. If you're going to exceed that one with per hour, magkakaproblema tayo sa heart. It can cause arrhythmia. Hypokalemia, remember that your potassium imbalance can cause arrhythmias sa ating heart. Okay? Do not give in high concentration because the patient will lead to your cardiac arrest. Mamatay na siya. Okay, mo nang I think one of the things that yung mga vets natin, if ever meron tayong terminally ill na mga dogs or pets, gina-injection na sila og potassium chloride. There are times wherein ginatagan na sila potassium chloride, high levels or high doses of your potassium chloride para mamatay to induce death. Okay? Must be incorporated with plain NSS kay hapdos po na siya kaayo atong potassium chloride. Okay? Ayan. And then for your nursing management, yes, no, monitor natin ang VS natin, especially the blood pressure. Pag hypokalemia is the ano tawag ito? Hypokalemia is commonly associated with hypovolemia, which can cause orthostatic hypotension. No? Hypo, puro sila hypo. Kasi 'di ba remember yung ating impulse transmission? Your impulse transmission is directly proportional to the levels of your potassium. Kung mababa ang ating potassium, if you have hypokalemia, of course, magkakaroon ka ng low impulse transmission. Okay? And vice versa. Okay? So you also have to check the heart rate and yes, ECG tracings tayo dyan. Okay? So mag-auscultate ka at the same time ECG tracings. Most of the time, nakahook yan sila sa cardiac monitor. Okay? Yan. So it can cause tachyarrhythmias. No? So sabi ko kanina that when we're dealing with imbalances of your potassium, arrhythmia tayo dyan. Aside from your potassium, you also have your calcium. Kuha? Kasi ito yung ating mga electrolytes for neuromuscular ano tawag ito? Neuromuscular functioning. Okay? So apektado yun ang heart ana. Assess for the respiratory rate and the depth of the pattern. Hypokalemia may weaken or paralyze your respiratory muscles. Kasi again, hypokalemia, mababa ang kanyang impulse transmission, expect na mababa or bababa din yung ating respiratory rate. Notify the doctor immediately if respiration becomes shallow and rapid. That means that nagkakaroon na siya ng adverse reactions for your hypokalemia. Okay, monitor, ito din, paano natin malalaman kung nag-improve ba yung serum levels ng ating client? Of course, serum potassium tayo. No, check for the diagnostic examination, no? Mga result. Okay, follow up niyo ang result. If ever the blood is taken already, follow up niyo yung result natin. Changes in serum potassium level can lead to serious cardiac complications and of course, administer potassium infusions cautiously. Kasi sobrang bilis, kung sobrang bilis niyan, baka sigang mata sa patient niya, matiurok na yung pasyente. So you have to be cautious on giving your KCl or your potassium chloride. Okay? Ayan. So I think we will be having a break muna. Question. Yes, yes. I'm sure hindi po ba magbaba ang glucose if i-treat po ang patient with insulin to lower? Yes, bababa yan siya. That is why nga yung B50 water. No? Okay. Sorry kung wala akong nabantayan, no? Ano pa? Have you yes, of course. Yes, mag-check ka talaga ng hypoglycemia. Pero kung sa hyperkalemia kasi, kung hyperkalemia yun siya, yung B50 water will induce hyperglycemia, no, para pair talaga yung magpasok. But still, yes, correct, no? Just to be more cautious, no, you have to check for manifestations of your hypoglycemia. Okay. Have you ever experienced, sir, na after nyo mag-poop kay unease imong anus? Oh. Sandali lang. Nakuha na ko na kurutan ko. Yes, oo. Labi na kanabit tong taod-taod nakalibang ka unya pag kanabit tong mura kag nagaihi nga nagalibang ng stream lang jud siya. Nang napan na ang sound effect kay sobra ka kusog sa pressure. Wala nag-ihi. Hapdos no pag ilo na ko dusa oy kanabit mo agi pa jud ang sabon sa murag. Usa ang management kaon og banana no banana tayo tapos if ever you feel like kasi of course matrauma ka man ayaw sa libang okay ayaw sa ipaabutig mga hours okay kay hapdos na po na inig ilo nimo no ayan sige so in my watch it is 5 o'clock break tayo 30 minutes see you at 5:30 sir kung black ang stool sir ano ang gawin you have to report that one that is basically your black tarry stool, that is your hematochezia, is your fresh, ano gani yung black, anyone, I forgot sa term. Hematochezia yung fresh, di ba? Yung fresh blood doon sa stool. Melena, your Melena. Ikuan jud, you have to evaluate first, or you have to assess kung ito mang imong tae, you have to check, isip-isipin mo, na ba ko gikaon nga itom? Gikaon nga itom. BBC. Dili, sorry, joke lang to, class, joke lang to. Okay, na ba ko gikaon nga itom? Na ba ko gikaon nga itom, no? Kasi 'di ba, remember doon sa ating dengue fever, no dark colored food or your NDCF, kasi it will mask if ever there is bleeding in your GI tract. So yun, mag-ask ka, na ba ko gikaon nga dark, anything dark? So, okay, na ba ko? Okay, ayan. Pero kung wala naman, you try to monitor again. Sa second stool nimo, kung itong gyapon na siya, oy, agoy. Naajud kay problema na kay kung black tarry stool, you have an upper GI bleeding tayo. Pag hematochezia naman, you have a lower GI bleeding dyan. Okay? Ayan, puros naman tayo atong istoryahan. Okay, so guys, see you back at 5:30. Sige, break muna kayo. Okay, I'm back and you're back and we're all back. Ayan, tapos maulan na, gabi na talaga ngayon, you know? If ever you get disconnected, don't worry. This is recorded, so I'll just be sending you the link mamaya. Okay? Before we start, no? Naman ko yung nagkuan dire. Nag-ingon nga magsayaw daw siya, icebreaker. Okay, no, from section H. Yes, from section H, nag-chat talaga sa akin, no? Gusto niya magkuan, icebreaker, no? Gusto niyang sumayaw. Okay, let's give it up. Let's a virtual round of applause, no, to our special performer. Yes, her name is, yes, babae po, si Miss Singson. Bili mo dyan, nag-flood. Miss Singson, saan ka na, Miss Singson?
Nag-request naman kong kanta, sir. Nga yung
nakapunta dito ako. Permission to dance. Oh, ano mo naka-meaning?
Sir, kanta mo ko na sa BTS.
Okay, no. Sige. I think mahiya pa si Miss Singson, no? Pero maybe one of these days, no, I will be letting you sing your hearts out, guys. Free for all, no holds barred na performance, no, just to release the tension. No, yung ginawa namin sa culmination or sa last day namin sa Cancer Immuno na kuan na program namin. Of course, I led the way kasi kami tanan dito mga yabag yun, may murag isa or duha lang siguro kabalo mo kanta. So yun. So we were having our voice was good, or our voice were good, pero yung boses ng iba better, no, dalawa sa kanila better, pero good yung boses namin. So here, no, maybe sometime, no, magkanta tayo, no, just to release, no. Ay, ito na lang. Okay, this we will be having an activity before we move on to our discussion. Magsabi ako, it's the love shot. Next, dapat sumpayin na ninyo katong na 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 na. Okay ba? Okay? I-release ninyo ang inyong frustrations, class. Okay? Sige. Sige, ha? Don't leave me hanging, guys, ha? Ayoko ninyo ipalaw, ha? Nanghangyo. Okay. Ready na? 1, 2, 3. It's the love shot. Ay, sige guys, bye-bye na guys. Oy. Lang naulaw ko. Off-cam na muna ako. Ayoko na sa world. Balik na ta. Nako. Jud may ayo ka. Okay, ayan, sige, break na tayo sa ating discussion. Okay, now let's talk about your hyperkalemia. It is, of course, etiology niya, increased dietary intake. Yes, of course naman, no? Pag marami kang kinain na food rich in potassium, most probably you will be having hyperkalemia, no? More than um, the needed na dietary intake, no? You also have there your blood transfusion. Ito. This is very important for you guys, no? Pag sinasabi natin blood transfusion, how many hours should you transfuse your blood to the patient? Let's say, for example, packed RBC. Ilang hours?
4 hours.
Very good, no? 4 hours. You have there 4 hours. Na-admit ko sa DMSF hospital for 18 days. That was my longest. Grabe. No? Kamatsuno na unta ko nganong no, I'm not questioning anong gibuhi ko, no. Sorry Lord. Thank you for the second chance sa akong kinabuhi. Okay. 4 hours. Okay, lami kay magpa-toxic dito. Of course kay kabalo man ka nga dapat 4 hours lang jud na siya. Lami kayo nang mambarubal alam pero sige na lang ay nagka-toxic kay kabalo ko nga bata pa man gutong staff dito. Okay. And then I was like asking, nung murag 12 hours na siguro to running ang ako ang blood transfusion. Tante nga lang, kung wala mo din undang. No, wala pa wala kayo gatulo because my veins at that time were obliterated. No, lisod kayo mangitag kuan sa kuha veins for IV infusion because of course I was dehydrated at the time and yun nga meron din akong acute renal failure or your AKI, acute kidney injury. Niya, pagsulod niya nangutan na jud ko, sir, pila din ni ka oras ni mudagan ning akong BT? Ay sir, okay ra man na sir, 12 hours. Sige jud ako mataba. Ay Jesus, Diyos ko Lord. May arjud. Okay? Because guys, if we will not stick to this 4 hours, what do you think will happen? Magkakaroon tayo ng hyperkalemia. Increase ang chances natin. One minus already. Nurse na boya to siya. Okay, hyperkalemia. Increase ang chances of the patient to be hyperkalemic already. Okay, aside from that one, dalawa po yan at electrolyte imbalance dyan. Hyperphosphatemia. Phosphatemia. Okay, phosphate ba? Okay, so these are the two electrolyte imbalances, hypers lang dalawa, that you would basically induce to your patient if ever you will be transfusing it longer than 4 hours. Bakit? Okay? Now class, kahit wala pong pa yan na transfuse, nagkakaroon ng hemolysis. Now remember, di ba sabi ko sa inyo, you have there your potassium, you have there your phosphate. Pico, ito siya pico, ito piso. Sa PI tayo, PI class, PI. Ang PI, sir. PIP. Potassium inside, you also have there phosphate inside. Both of these are intracellular, anong tawag dito? Intracellular electrolytes. Okay, and they are the most abundant sa cation and sa anion. This is for the cation, this is for the anion, di ba? Now, your blood, basically packed RBC natin, will undergo hemolysis kahit na hindi pa yan siya transfuse sa inyo. Okay, slowly nagkakaroon ng hemolysis. When we're talking about hemolysis, this is blood, lysis is the breakdown. Magbe-breakdown yung ating red blood cells. Kung ito yung ating red blood cells, yung donut shape natin. And remember, your potassium and your phosphate are inside your red blood cells. Magla-lyse yan sila. Pag mag-lyse yan sila, okay, release yan sila from the intracellular. It will now occupy your extracellular. Kuha natin. So by the time that it will be transfused already, meron ng mataas na potassium levels and phosphate levels doon sa ating packed RBC na bag. Okay, and that's the reason why dapat within 4 hours lang talaga. In San Pedro San Pedro Hospital, hanggang 6 hours. No, they extended up to 6 hours yung transfusion natin. More than that, gina-stop, gina-terminate na yun na siya. Okay, so ay yun mo pakaulaw-ulaw dito nga, ay, okay ra na sir, 12 hours, oh, very confident pakaayos. Sus, langas na pa yun akong utok ato because of the CREA, BUN, sige, circulate lang sa akong utok. Okay, so you have there, anong tawag dito, yun ang mangyayari, no, hyperkalemia and hyperphosphatemia. Okay? So doon pa lang mismo doon sa blood bag na yon, okay, meron ng hyperkalemia and hyperphosphorus, or there is a build up, I'm sorry, there is a build up of your calcium, potassium levels and your phosphate levels. Okay? Sorry, serum potassium. So you have to check, monitor serum potassium level. Okay? Increases longer os. Ito, nasabi ko na to. Rapid IV potassium administration. Yes, nagkakaroon ng hyperkalemia dyan. That is why you have to be cautious in administering your potassium chloride. Renal insufficiency can cause hyperkalemia as well. Bakit? Problema natin kidneys natin. Insufficiency, that means that nagkakaroon tayo ng problema sa kidneys. Remember that your kidneys also excrete your potassium. Okay? Kung hindi na magana yung potassium natin, or remember, raas din, raas. Okay, what helps in the excretion of your potassium is yung aldosterone natin. And remember, it will not function anymore because naatay renal insufficiency. Renal insufficiency, pwede yan siya renal failure dyan. Okay, so your kidneys are failing already. So ang mangyayari dyan, magkakaroon tayo ng build up of your potassium. Kaya sa renal insufficiency, usually, or renal failure, magkakaroon tayo ng hyperkalemia. Okay, it goes hand in hand talaga. Okay, or magkasabay talaga yan sila. After mo magkaroon ng renal failure, of course, you will be expecting the patient to have or to develop hyperkalemia. Okay? And dyan napapasok yung D50 water natin plus insulin. Okay? At that time, ako wala makugyat agad, ana. No, within the normal levels man akong potassium. It's just that yung calcium levels ko mababa. Okay? And then I will be discussing that one doon sa ating hypocalcemia, kung ano yung management doon. Another etiology, metabolic acidosis. Your potassium shift to ECF, no, from the intracellular going to the extracellular. So yung ating extracellular doon sa ating plasma, yung blood plasma, tapok na sila dira, so mutaas ang potassium levels, leading to your, anong tawag ito? Metabolic acidosis. Okay? Ayan. Pag magkakaroon tayo ng metabolic acidosis, first compensatory mechanism of the lungs for the manifestation, for the manifestation, ano yung sabi ko sa inyo? Cosmos. Okay? Cosmos respiration. Sir, ano bang nangyayari sa cosmos respiration? This is now your fast breathing. Okay? I think that was deep, no? Deep tapos fast or shallow. No? Basta ang sure lang nako is mabilis ang paghinga niya or ang pag-exhale niya. Okay? Ayan. Wait lang. So going back, you have here the ECG abnormalities of your hyperkalemia. STI tayo dito. So you remember your STI na school. Yung kanina doon is yung UST natin. Dito naman, STI tayo. So for your S, it is the ST segment depression. Okay, magkakaroon tayo yung ST segment depression. You also have there your T or peak wave, no? Tall peak wave. Okay, or I'm sorry, no. Tall T wave or peak T wave. No, duha na sila, no? Same lang na sila og picture sa ECG. You have there your tall T wave or peak T wave. The next is your I for your interval or your prolonged PR interval tayo dyan, no? So your interval is prolonged for your PR. Okay? Yung PR interval natin. So this is the normal. Okay? So as you can see here, mono siya ang atong PR interval, which is prolonged. If you're going to compare it with your normal PR interval here, very short lang, dito mataas. Okay? Aside from that one, you also have there your wide or flat P wave, which is not indicated here. And you also have there your widened QRS. Ito yung sinasabi natin. Dapat mas mataas kasi yung ating QRS compared to your T wave. Okay, yung T wave natin dito, rounded. Okay, ang peak niya dito, tall, peak T wave. So ayan, pointed pa talaga. So mas mataas siya sa inyong QRS complex. Kuha natin. So ito yung makikita ninyo usually sa mga patients with hyperkalemia. Ayan. So these are also para mas madali ninyo ma-remember if you are visual. So for your hyperkalemia, more than 5, no, yung kanyang I think that is 3.5 to 5 So more than 5, that indicates already your hyperkalemia. So your treatment there, you have there your calcium, insulin, di ba? Insulin plus D50 water. Okay? Ayan. Pero sir, kung diabetic unya nasa hyperkalemia, wala nang problema kasi meron ka ng hyperglycemia doon sa diabetes mo. If ever nasa hyperglycemia, pwede na siya walang D50 water. It will just be the insulin. Kuha natin. Ayan, kasi mataas na dan yung yung potassium levels and yung inyong um, glucose levels in the blood. You also have there your albuterol and your kayaksalate. I will be discussing your kayaksalate mamaya, no? Okay, bakit ito binibigay? You also have there, pag dialysis class, ay, sir, pag hyperkalemia, dinadialysis ba? Yes, in severe cases. Okay? And remember that it can cause, your hyperkalemia can cause cardiac dysrhythmias. Doon sa kabila, your dysrhythmia, in some books, no, dysrhythmia and arrhythmias, they are synonymous. No? In some books, yung arrhythmia ninyo or your dysrhythmia is the general term, and then below your dysrhythmia, yung mga subclassifications yung dysrhythmia ninyo. When we see dysrhythmia, no, naglisod na og rhythm, no, to have a pattern of the beating or the electric conductivity of your heart. Okay? So in some books, yung arrhythmia nyo is a type of your dysrhythmia. Kuha natin. Ayan. Or vice versa. Okay? So you also have your intestinal colic. Yes, yung sabi ko sa inyo, diarrhea because of your directly proportional yung inyong impulse transmission and with the levels of your potassium. Kung mataas yung potassium natin, mas mataas yung impulse transmission natin. Kaya nagkakaroon tayo ng diarrhea. Okay? Kasi mabilis yung yung paggalaw ng ating bowel movement. Okay? You also have their muscle weakness and your paralysis. Okay? Yung ating paralytic ileus, saan yun siya? Sa hypokalemia. Okay, eto. So these are the management for your hyperkalemia. Okay, remember you're going to give diuretics. Anong klaseng diuretics? Yung mga potassium wasting natin. You have there your Bumex, your furosemide, your thiazide, and your mannitol. So meron tayong mga hypertonic to siya. You have there your loop and your thiazides. Okay? Ayan. So, muna sila. Okay, your furosemide is the loop. Your thiazide is I think your Bumex is also your thiazides. Your hydrochlorothiazide is, of course, your thiazide. And your mannitol, dili na siya appeal din, no? But it is also a diuretic, a hypertonic diuretic. Okay, for your cerebral edema. Next is your kayaksalate. Now, remember that your kayaksalate, this is the name, no, or your generic name for your kayaksalate. Sodium polystyrene sulfonate. Meron siyang content of your sodium. Okay, basically it is a sodium talaga eh. Okay, now pag sinasabi natin kayaksalate, this is an exchange resin from the word, remember this one, exchange resin yan siya. How is this being administered? It is administered via PO or enema. So dadaan talaga yan sila sa inyong gastric organs or sa inyong gastric tract or sa inyong GI or inyong digestive tract. Now remember yung enema natin, of course, you have there your kayaksalate. Okay, asa man na siya administer when we're talking about enemas or mga enema natin, asa man na ginapaslak. Sa lubot na siya ginaagi ha. Sa lubot. So basically, you will be infusing your enema or your kayaksalate doon sa inyong GI tract ninyo. So you have there ito, tapos transverse, ascending, and okay. And then you have there your small intestines. Okay. Now remember that when we're talking about your kayaksalate as an exchange resin, this is sodium talaga. Okay, ang content niya ng sodium. Pag sinasabi exchange resin, what it does now is that it will now have an exchange, no? Your sodium will go into your anong tawag ito? Will go into your or papalitan niyo yung potassium niyo dito sa inyong intestine para dili siya ma-reabsorb. So magkakaroon ng exchanging of your potassium para yung potassium ninyo, it will now be readily excreted kaagad dito. Okay, ang problema ngayon yan, you have to assess the bowel movement of your anong tawag ito? Nursing consideration, you have to assess the bowel movement of your or whenever you're administering your kayaksalate. And of course, you have to watch out for hypernatremia kasi yung sodium natin, ito na yun siya ang papalit sa inyong potassium. So there will be an exchange, no, from your doon sa potassium ninyo, okay, lalabas yan siya, pupunta yan siya doon sa inyong kuan, sa inyong intestine para ma-excrete, while your sodium will be diffusing doon sa ating, or will be exchanging itself doon sa ating intravascular, sa ating kuan, blood vessels natin doon sa ating intestine, no, para ano tawag ito para ma-absorb yun siya. Okay, so there will be an exchange. Once ma-exchange siya, ma-excrete yung potassium natin, now the patient will be at risk for having hypernatremia. So you have to check as well yung serum levels niyan, okay, after administering this one. Okay, naman sila monitoring every day. Okay, or pwede po, kung stat, pwede mo siya ihatag kaagad. Okay, and another treatment for this one, yung sabi ko, insulin plus D50 water. I've already discussed this one para to correct the ratio. Okay, para hindi siya magkaroon ng, if the patient does not have any hyperglycemia, hyperkalemia lang siya, ito yung ibibigay natin. Okay, kung ang patient natin walang hyperglycemia, we're going to add D50 water para makorek yung ratio ng ating potassium, which is already mataas na kasi hyperkalemia tayo. So by pairs sila papasok sa cell. Okay, so that we will prevent yung ating glycemia. Okay, low levels of glucose in the blood. And then if severe dialysis, nasabi ko na ito. Okay, now here's the thing. We're talking about your hyperkalemia. Okay, hyperkalemia tayo ha, kalemia. I-connect na ngayon natin yan. Di ba marami tayong mga types of anti-hypertensive drug or anti-hypertension na mga drugs? Okay, meron tayong beta blockers, you have there your ACE inhibitors, sa pa ba to?
Calcium channel blockers.
Exactly, very good. Thank you very much, Mr. Odokayan, for helping me. Calcium channel blockers, which among those that are mentioned ang dapat nato nga i-avoid? For a patient who has hyperkalemia, try to analyze. Beta blockers, calcium channel blockers, ACE inhibitors. Asa dito? Kasi if you're going to give that one, samot ang hyperkalemia sa patient nato. Anyone who wants to guess? So natay A, calcium channel blockers. B, ACE inhibitors. Letter C. So itong letter C na to, beta blockers. Meron nag-chat. Sabi ni Mr. Sabi dito, ACE inhibitors, sir. Wild guess lang. Meron na tayong isang answer. ACE inhibitors. Ano yung iba? Nag-a-analyze pa? Meron pa. C. Ayan. Sige. Sige ha. Sige. Key in your answers in the chat box. Sige. Key in your answers. BNC. Paano yan? Dalawa yung isi-shade mo, Mr. Cole. Doon sa inyong board exam.
Naman
Ayan.
na choices D, sir.
Okay. BNC. Yes. Sige. Okay, ayan. I-discuss na natin. Okay. The correct answer is, for the wild guess, tama. ACE inhibitors po tayo. You do not give a patient with hyperkalemia ACE inhibitors. Now, since we know the answer already, the correct answer, who can tell me bakit hindi natin to ibigay itong ating ACE inhibitors sa patients with hyperkalemia? Anyone? Okay. Kung meron kang alam sa sagot, raise your hand. Yung pinakauna maka-raise ng hand, merong premyo. Sige na, who wants to raise or who has an idea? Kahit trial lang, kahit try lang. Merong pa-Gcash na 100 piso. Sige, ayan. Sige na. Ang wild guess daw na Mr. Coronel. Wala ba na yung premyo? Okay. Nakakuan ka. Tama itong imong wild guess. Anyone? Ay, dili sila ganahan sa 100. Yes, Miss Amba. Ayan, Miss Amba. Go ahead.
Ginapa-lower niya ang aldosterone, sir.
Ginapa-lower niya ang aldosterone. Yes, exactly. Tama. No? Very good, Miss Amba. I will be getting your GCash number para i-send ko mamaya sa yung premium mo. Okay. Ginapa-lower niya ang aldosterone level. Nga no, ginaunsa niya pagpa-lower. Ginaunsa niya pagpa-lower. Remember, this is your ACE inhibitor. What does it inhibit?
Pag-convert, sir, sa angiotensin.
Very good. No, to convert your angiotensin 1 to angiotensin 2 kasi once it becomes your angiotensin 2, it will now react to your what? Kidney and your adrenal glands. Pag mag-react yan siya sa adrenal glands mo, it will now stimulate the release of your aldosterone. And remember, I keep on saying this one, once your aldosterone is released, it will act on your kidneys, not to what? To conserve your sodium. There will be an increased reabsorption of sodium, pero 'di ba? Sabi ko, yung inyong potassium and your sodium, they are inversely proportional. So ang mangyayari diyan is that there will be an increase ano tawag ito? Excretion of your potassium. Kuha natin. Ayan, kaya dapat hindi ACE inhibitors ang binibigay natin. Okay, kasi dili ma-excrete ang atuang potassium. Ayan. So pwede to sa A or B, no? Ito i-avoid talaga natin. Okay, pero good job gihapon sa nag-wild guess. Anong mo po to imong naisip nga i-answer, Mr. Coronel?
Feel lang na po, sir.
Sana all, no? Lahat makuha sa feelings, no? Okay, para makapasa sa board exam. Okay, sige. Good feel. Okay, let's assess nursing management, yes, assess the vital signs. INO tayo. Okay, report an issue of less than 30 ml per hour. Bakit yung aking ihi noon per hour, that was like 20, no? 20 or below 20 pa talaga per hour. Unya nasuya ko kay suksukan jud ko og kuan catheter. Hate mo itong pinaka-hate na ako. It limited my movement, no? Gi-check good na ako dayon, no, after na remove tong catheter kung naga-function pa ba. Kung makagising pa ba siya. Hey, are you okay, no? Ay ana day pagmata, sir. Okay, anyways, no, going back. Anong tawag ito? Bakit less than 30? Because you're expected to have 30 or more ml per hour of your urinary output, especially kung nakakuan ka, catheter ka talaga, because it will really monitor talaga, no? Yung urinary output mo talaga. Okay? Bakit? Because if ever below yan siya, of course, you will have there your renal insufficiency already. It will now tell you that insufficiency. Ambot lang kung double F ba na siya, ha? So, siguro. Okay, renal insufficient, that means that naga-fail na ang imuhang kidneys. And if your kidneys fail, remember that if ever your kidneys fail, tataas yung ating potassium levels dyan. Okay? Kaya wala naman tong raas na to. Aside from that regulatory mechanism, nawawala yung raas natin. Prepare to administer slow. Ito ang binigay sa akin, no? Slow calcium chloride or gluconate. This is now to counteract your myocardial depressant effects of your hyperkalemia. Because remember, dito sa ating hyperkalemia, magkakaroon tayo ng arrhythmias or dysrhythmias. Okay? So binigyan, aside from having a low calcium levels, no, double purpose yung calcium gluconate. Okay? And remember, class, if ever, no, may times kasi intern yung nagbigay nito or resident ang nagbibigay ng calcium gluconate, and then you will be attaching the patient to ECG. Nag-ECG monitor ko nila every time mag-calcium gluconate ko. You have to remember that you're going to do a slow IV push. Dako kayo na siya, class. Dako kayo ng syringe ng gamiton. They're just gonna push it doon sa white port ng inyong IV solution. So, slow IV push tayo dyan. Okay, slow talaga, no? Pati tong resident on duty at that time, tanaw ko sa iya, makatulog na lang good siya. No? Kasi slow talaga yan siya. Minutes talaga yan, mga 30 minutes to 45 minutes na dito. Okay? Kaya there is a possibility na it would cause arrhythmia as well, no? Or dysrhythmia or mga irregularities with the beating or the electrical conduction of the heart. Okay, so binibigyan yan siya ng um, calcium chloride or your calcium gluconate solution. Kuha natin. Keep in mind when giving Kayexalate at serum sodium levels may rise. Ito yung sabi ko sa inyo na magkakaroon ng hypernatremia. So watch signs of heart failure. Okay, kasi nga, if your sodium level rises, tapos you have a normal blood volume there, tataas talaga yung blood volume natin. And then it will increase the chances of having heart failure, congestive heart failure to your patient. And of course, lastly, monitor ECG talaga tayo dyan. So you have here your nursing management, your hyperkalemia, all of the things that I've said, makikita nyo dito. Okay? But if you want to use this one, ito na slide na ito, dito na slide, no? Mas okay naman, wala nang problema. Okay? Anyways, all of these are discussed already in the prior slides. Okay, ito yung Kayexalate natin. Okay? And you also have your regular insulin plus your D50 water. Okay? Ayan. And let's now go to your calcium. Malapit na tayo matapos class. Calcium tayo, bone formation. These are the functions of your calcium. Bone formation, clot formation. So if ever you will be having problems with your calcium levels, pag hypocalcemia yan siya, magkakaroon ka ng risk for bleeding. Okay? Important for impulse transmission as well. That means that it is inversely proportional. Pag mataas ang ating calcium levels, there will be a decrease in impulse transmission. Magkakaroon tayo ng hyporeflexia. Okay? Dili siya kuan ba sensitive hyporeflexes, no? Magkakaroon ng hyporeflexia ang patient natin. Manifestation of your decreased impulse transmission, again, they are inversely proportional. Hypotension, paralytic ileus, no? And intestinal colic. Same lang gyapon sa ato ang hypokalemia. Okay? Dili siya hyperkalemia ha? Because remember, yung hypokalemia natin, it is directly proportional to your impulse transmission. Okay? So kung mababa yung ating impulse transmission sa ating hypokalemia, that means that decrease ang bowel movement. Same with your hypercalcemia kasi mababa yung impulse transmission natin dito. So magkakaroon pa rin tayo ng paralytic ileus which can result into your constipation. And then of course, intestinal colic as well. Pag mababa naman ating calcium, which is hypocalcemia, increase ang impulse transmission dyan. Magkakaroon tayo ng hyperactive reflexes or hyperreflexia. And then meron tayong tinatawag na Chvostek and your Chusosine. Okay, everybody say Chvostek.
First step.
Duha ra ka buok. Everybody say Chvostek.
Vostek.
Ang uban ba ako ng sige na lang. Hapit na lang kita mga class. Okay, glands regulating your CA levels. I will be teaching you kung paano mag-assess ng Chvostek natin and your Chusosine. Okay? Mamaya. So you have there the glands regulating. You have your thyroid gland, T3. Remember that your thyroid gland releases or produces your T3, T4 or your triiodothyronine and thyroxine. Wala tayong pakialam dito sa ating FNE. Wala tayong pakialam dito. Ang pakialam natin is yung thyrocalcitonin or your calcitonin because that is the one that regulates kung mataas ang ating if there is an increase in the calcium levels, no, imbalance na mataas. Okay? So what stimulates it to be released? Yung sabi ko sa inyo, mataas, high levels of your calcium. Okay? I-release or there will be a secretion of your calcitonin pag mataas yung ating calcium levels. Kung may hypercalcemia, si calcitonin ang bahala dyan. Okay? So your calcitonin will act on your kidney, your intestine, and your bone. How? Pag dito sa kidney natin, class, there will now be an increase in the secretion of your calcium. Okay? Increase excretion of calcium. Dito naman sa ating intestine, okay? Decrease reabsorption of calcium. Okay? And for the bone naman, there will be deposition. So magiging deposits, magkakaroon ng deposits, no, from from the increase in your blood calcium levels, the deposit na siya doon. Okay, there will be deposition of calcium. Okay, doon sa bone, to the bone. Ayan. And let's talk about your parathyroid. Remember, this is the counterpart of your thyroid gland. Pag ito, parathyroid, it secretes your PTH or your parathyroid hormone. What stimulates it to be released? Of course, kung ito mataas, dito mababa. Okay? So, ang effect niyan, ang effect ng calcitonin natin is to lower down your calcium para magkaroon ng homeostasis. Para mabalik niya sa balance. Ito naman, pag decrease ang calcium levels, pinapataasan ng parathyroid hormone mo yung calcium levels mo para magkaroon ng homeostasis pa rin. Kuha natin. Homeostasis. Okay? Now, for your parathyroid hormone, ano bang ginagawa niya? Sa kidney natin, what happens there in the kidney is that aside no, from the stimulation of your vitamin D activation or vitamin D or forming the vitamin D, yung ating calciferol, if I'm not mistaken, no, para mag-increase, no, kasi your vitamin D will act on your intestine to increase the absorption of your calcium. So dito sa intestine, increase absorption of calcium. Sa bone natin dito, okay, there will be an increase in osteoclast activity. Diba? Diba, remember your osteoclast? These are the bone destroying cells. So this one increase osteoclast activity. Okay. Sa kidney naman, it has something to do with the vitamin D formation. Yung active form ha, daghan magutag vitamin D class. Pero once if we cannot if your kidney cannot metabolize those inactive form of your vitamin D, dili gihapon na siya magamit sa atong lawas. Okay, dapat niya na i-transform into your active form, which is your calciferol, para it will now be the activated vitamin D. It will now go to your intestine para yung intestine mo, it will now increase the absorption of your calcium. Okay? Vitamin D formation, yung active form. Okay? And of course, there will be an increased excretion of your calcium sa renal tubules natin. Kuha? No, osteoporosis, pag ang patient merong osteoporosis, expect hypercalcemia. Okay? And another thing about osteoporosis, okay? If you have hypocalcemia, okay? If you have hypocalcemia, it can lead to your osteoporosis. If you have osteoporosis, it could lead to hypercalcemia. Kasi nagbe-breakdown yung ating bones dito eh. Okay? Nagbe-breakdown yung ating bones. There will be demineralization. So from the bones, no, magsusoften or magiging brittle yan siya. So lalabas ngayon yung ating mga calcium salts or calcium ions and it will be released in your bloodstream. Okay, magkakaroon ng hypercalcemia. But then again, yung hypocalcemia natin can lead to osteoporosis and then yung osteoporosis can lead to your hypercalcemia. Kuha natin. It's not about your hypercalcemia can lead to your osteoporosis. No, your osteoporosis will lead to your hypercalcemia. Kuha natin. Ayan. So what is the etiology for your hypocalcemia? Hypocalcemia natin below the normal range. Yung normal range natin is 4.5 to 5.5 milliequivalents per liter. Inadequate intake pa rin. Yes. Hypoparathyroidism. Okay, remember that diba your parathyroid gland, they are the ones that regulates kung mababa. Sila yung nagpapataas. Eh kung wala ito, of course, bababa talaga yung hypocalcemia na or bababa talaga yung ating calcium levels in the blood. So your hypoparathyroidism resulting from your surgery, kung tinatanggal yung ating parathyroid gland or your thyroidectomy. Kasi if you're going to remove your thyroid gland, kasama na kadto dyan yung ating parathyroid. Diba kung monit sa atong thyroid gland, you have there your parathyroid dito. Okay, so kung remove yan siya, remove talaga ito. Okay. Electrolyte imbalances, low serum albumin levels, most common cause. You also have there your malabsorption, from increased intestinal motility. There's also vitamin D deficiency. Yung sabi ko na nga sa inyo kanina, pag walang vitamin D activated form, of course, there will walang mag-stimulate to increase the absorption of your calcium in your intestine. Okay, vitamin D deficiency due to lack of sun exposure. Again, class, yung vitamin D natin, it's not coming from your sun or yung sa sunlight natin. No. Once the sunlight or the UV rays or the UV light touches the skin, that's the time we're in magkakaroon ng metabolism. Kuha natin. Ayan, massive blood transfusion, liver unable to metabolize citrate, kaya nagkakaroon ng to prevent clotting natin, You also have there your chronic diarrhea, diuretic phase of your ARF. Okay? Kasi nga, there is renal insufficiency. So, hindi na siya makakreate ng vitamin D production, and then at the same time, pag walang vitamin D or walang activated vitamin D, ayun, magkakaproblema tayo sa ating levels. No? Bababa talaga yung ating calcium levels. Kasi there will no be or wala na mag-a-absorb ng calcium natin no, doon sa ating intestine. Okay? You also have their severe burns. Bakit? Bakit severe burns? Nasusunog yung ating panit. Okay? Yung mga Adobo Republic dyan, no? Itaas natin mga kamay sa mga maiitim dahil sila ay hot. Sa sobrang hot nila, nasunog. But in literal, pag sinabi natin severe burns, it will now, let's say for example, third or second degree burn, it will now affect no, your epidermis and your dermis. And remember ba yan, no? For one of which or one of the factors kung bakit nagkakaroon tayo ng mga inactive forms of vitamin D is because of the interaction of your UV rays doon sa ating skin. Okay, so magkakaroon tayo ng inactive form of vitamin D, tapos yung vitamin D na yun, yung inactive form, it will now be transformed by your kidneys para maging active form, para magamit ng ating intestine. So severe burns because of your impaired tissue, okay, or organ, yung skin natin, kaya nagkakaroon tayo ng problema sa ating calcium levels. Bababa yun. Okay? Ayan, so these are the manifestations of your hypocalcemia. Meron tayong CATs na tinatawag, your convulsions or seizures. Magkakaroon pwede rin. So you will be placing the patient in seizure precaution as well. You also have there your arrhythmias. Okay, kaya binibigyan natin yan sila ng calcium gluconate para to prevent arrhythmias. You also have there your tetany. Ano sama ng tetany, sir? This is a manifestation that can be also seen or that can be seen in patients with infected with Clostridium tetani natin or tetani. Okay ka na mga C tetani natin. When we see tetany, this is now muscle spasms. Okay, meron tayong tinatawag dyan wherein sa severe muscle spasms natin sa likod, kung meron kang tetanus, there will be an arching, no, hyperextension sa likod natin. So mag-arc talaga, magbe-bend talaga yung sa likod natin, arching. Tapos, ano lang dyan siya, mag-spasm lang dyan na siya. Okay? And you also have there your spasms and your stridor. Dito na spasm class, this is not about the muscle spasm. Ito yung tetany, yung muscle spasm natin. This is what we call your broncho spasms. Okay? And you have there your stridor. These are ang stridor natin is an example of your adventitious breath sounds. Pag sinasabi natin adventitious breath sounds, if you could still remember your HA, okay, yung adventitious breath sounds natin, these are abnormal breath sounds. Diba? Andyan yung rails natin or your rows, crackles, wheezes. Pag sinasabi natin stridor, most of the time, when can it be heard? During inspiration or expiration? Stridor.
Inhalation, sir.
Yes, exactly. Inhalation because it is I. Ang wheezes natin, remember the E sa wheezes, that is exhalation. Okay, so during inspiration, ano na siya? Ang wheezes, o tapos both, o ano na siya? Okay? So those are your bronchospasms. Okay, now, you also have there your ECG changes, prolonged ang QT interval, neuromuscular irritability. I will be showing you this one. Okay? This one is because of the fact na nagkakaroon ng hyperreflexia. Remember that your impulse transmission is inversely proportional sa inyong hypocalcemia. Okay? Kaya nagiging, pag sinasabi natin hypocalcemia, mataas ang or mabilis ang impulse transmission, nagiging hypersensitive ito to touch. No? Gamayng kuhit lang, twitch na ang pasyente ninyo. Okay? And if ever the patient will undergo or experience bronchospasm, that will be the priority kasi airway ito eh. Airway. Okay? Question. Meron tayong question dito. A patient is having airway obstruction. What do you think is the most common presentation of airway obstruction? Nana-type choices. Ano wala mo ni A? A, B, C, D. Wait lang, kinsa ganitong, wala na ko na lista. Kinsa ka ito naka-answer ganiha gani sa ACE, bakit ang ACE inhibitors?
Si Leia, sir.
Last name?
Amba.
Okay, Amba. Okay, ito. Anyone from the class, answer kayo, answer. Chat nyo lang ang answer ninyo. Saan dito? What do you think is the most common presentation of airway obstruction? Wild guess na po si Kuan. Mr. Coronel. Yes. No, sorry, wala ako naka-reply kay Mr. Dalipe. Yes, correct, no? Related to their effects sa ranin. Yung kanina. A, sir. Nay A, nay D. Nay A, nay D. Sige, keep it coming, no? Sige, nay B. Sige. Let us discuss. Let's try to sa tawag ana eliminate na to. D, tapos may tawa. Okay. Sige, happy siya kahit pinili niya yung D. Okay, cough. Okay. Pag sinasabi natin cough, guys, you will be expecting this is the common classical sign of your respiratory problems. Lahat ng respiratory problems will involve cough. Respiratory problems. Meron kang manifestation of your cough. Okay? Respiratory problems. Lahat talaga. We're talking about airway obstruction dito. Okay? So your respiratory problems, dili na siya. Okay? All of the respiratory problems will have cough. So A is not the answer. Dyspnea. Okay? Pag sinasabi natin dyspnea, still the same thing. Okay? Anong tawag dito? Nahihirapan kang maghinga. Okay? It does not necessarily mean that if ever you are having a hard time breathing, kasi when we're talking about dyspnea, it's having a hard time breathing. It does not necessarily mean that if you're having difficulty of breathing, meron ka agad airway obstruction. No, dili. Okay, what about anxiety? It gives you dyspnea, it gives you difficulty of breathing, okay, but you don't have any obstruction. So hindi pwede ang ating dyspnea. How about hypoxia? Okay, guys, when we're talking about hypoxia, it does not necessarily mean as well that anong tawag dito? That your hypoxia is a common presentation of your airway obstruction. Okay? Kasi class, pwede naman na magkakaroon talaga ng hypoxia ang airway obstruction. But there are also anong tawag dito? There are also causes or etiology that would cause your hypoxia, such as your obstruction. Okay, magkakaroon ka niya ng hypoxia. Okay, common presentation of your airway obstruction. It is basically your noisy breathing. Yung ating kuan. Answer is letter D. So congratulations no on choosing letter D for your noisy breathing. Kuha natin. That is why class, kung naa kay wheezes, no, kung ang patient nimo girush sa ER with wheezes, okay, meaning naa pa nay buslot ang inyong kuan. Though it is already constricted, pero nagihapon na siya buslot ang inyong airway. Medyo patent pa na siya. Dili jud medyo kanang somehow it is compromised already. Makulbaan mo ana class that if ever a patient with asthma is delivered to the or is sent to the ER department, brought to the ER department pala, asthma siya, tapos nagka-wheezes, taod-taod nawala ang wheezes niya. Okay, pasalamat mo nga magka-wheezes na siya because of the fact that if ever, okay, sir, what if nawala ang wheezes niya tapos cyanotic pa rin yung patient? What do you think? What do you think is the reason bakit nawala yung inyong wheezes?
Di na dyan siya kahinga, sir.
Di na dyan siya kahinga. Okay. Yes, of course, di na dyan siya kahinga. Bakit? Bakit hindi na siya makahinga? Because now, yes, go ahead, Mr. Odokayan.
Char lang. Wala na nag-stimulate sa kanya, sir, para mag-breathe.
Wala na nag-stimulate sa kanya para mag-breathe. Okay. Good try. That is for your COPD. No, most of the time COPD yan masobraan og hatag og oxygen. No, wala na di na siya ma-stimulate og breathe. But for the case of your wheezing, yes, tama si Miss Ocampo, nag-closer ang airway. There is now complete closure of your bronchus. So nag-spasm na dyan na siya. And that is what we call your status asthmaticus. Okay, kaya binibigyan na yan siya ng drug of choice for your status asthmaticus, dili na siya bronchodilators, di ba? Yung bronchodilators natin, mao na siya ginahatag nato or kanang salbutamol, mao na siya tong or katong puff nato, mao na ginahatag sa atong patient sa mga asthma. Pero kung there is a complete closure already, ano yung binibigay? Anyone? It is an ER drug. Uy, may nag-chat. Yes, very good. Very good, Miss Gonzaga. That is your epinephrine. Okay, that is for your status asthmaticus. Okay, ayan, that is for your hypocalcemia. This is what we call your chusol. Normal ba ning inani class? Kung bipihan mo mag-ana inyong kamot, di ba dili? Dili. Ako nalimot tubag. Dili na siya. Okay, this is what we call your chusol sign. You have there the tourniquet and then you're going to inflate the tourniquet. Now remember, sa ating hypocalcemia, increase ang ating impulse transmission. That means that there is hyper reflexes or reflexia. Kaya ito, sa sobra ka-sensitive, muana na siya. Okay, mag-contract yung muscles mo ngayon. Ba normally, pag magpabibita, ana lang man na, wala man yung ana-ana sa inyo ha. Okay, that means that this is your hypocalcemia. Your Schwovstek. I-try ninyo sa inyong mukha ngayon. Maganon kayo. If you feel any twitching no sa inyong baba or dire sa inyong mata, okay, that is basically your Schwovstek. Meaning ana na amoy hypocalcemia. Tanawan niyo dire on, nilihok iyang dire. Wala man nilihok sa kuha. Wala naman na pag-aral ni mo. Wala naman na. Okay? So this is your Schwovstek. Okay, another one. Di ba? Uy, sir, nalagi ni siya kuan. It's either na gioperahan ni siya, no? Gitanggal ang iyahang thyroid gland or your parathyroid gland. Okay? So, basig parathyroidectomy ni siya or thyroidectomy. So, nagkakaroon ng hypocalcemia. This is another, same na ni sila, Schwovstek niya. Okay? Ayan. So, sabi kasi ng mga CI, kailangan daw ng mga stimulating na mga slides. So dapat kung hypocalcemia, supplementary natin is yung ating dairy products, yung milk natin, no? Mama milk, mama kutaw milk, okay? So you have here no kung kailangan jud iko ano iyabo sa lawas ang milk no. Naday na siya ikuan. Nagkalas-kalas ra jud sila gatas no. Ayaw na daw i-move ang slide. Tama daw class. Naku ichika. I remember no kay nagkita ko nung nagbugdo iya. Grabe tong sa kuan sa Nigeria, I mean the school doon. Of course, you have there the Africans. So syempre mga BBC na sila. Unya mangihi lang na sila masing asa. Unya kami after playing tennis, of course, baktas mo kayon naman kasi nag-lower down na tong sympathetic nimo so parasympathetic na. So kailan na mangihi, ka-feel ng urgency of mangihi. Maulaw na lang gud mi mangihi dito, no, sa kilid-kilid. Na yung mga students nga nagaihi po sa kilid-kilid kay makita ni ato ang kuan tender juicy hotdog kanang kuan pa jud cocktail no tidbits. Okay, so, maulaw na lang jud ka bitaw class no. Ambot nga sa Africa jud ako gusto no. Grabe sila ka kuan dito. I mean their genes. So ang mga bunal di perting dagkua. There was a patient that was underwent dialysis unya nagkuan ba. Nag-insert og catheter. Nagdakuha niyo. At rest pa to ha, at rest. No, di ba maglisod man kaana mo insert og catheter pagkuan ni tindog. At rest po to ha. No, nagdakuha niyo. So ayun. Okay. They are blessed talaga with big things talaga. Even the females doon, most of them, dira po daw, miss. Help the needy. Okay. Kay naman ay times no kanang we go out. I mean na lock kasi kami sa campus lang talaga kay pag makagawas mi, makidnap mi kay ang tanaw nila sa amua is mga white no masking itom si sir pag abot dito white white puti kay ko ginatawag ko nila white man onotcha, it's what they call onotcha, white man. White man sa manilang mata plastic siguro. Anyways no mga demon or kanang mga maldito pud kini makauban ako nga malaki so mag-drive na sila muadto na sila sa girls hostel no. Unya sa gawas lang yun na sila mga ligo class Pataya ani ni Loy, or not really ka na maligo ka na totally naked okay, mag-nighties ra na sila dito, no ko kagiatay man mo tawhanan mo muagi magyud na sila dito. Grabe, dagko jud sila kuan class, dagko sila hinaharap, dagko sila lubot. They are very blessed talaga, no, gamay lang jud yung makita dito nga walay kuan, wala kaayoy breast, wala kaayoy lubot, no, murag gipading. Okay, ayan. Stimulating. So, treatment for hypokalemia, of course, imbalance tayo, mababa or mababa tayo. Of course, supplement calcium talaga tayo. Ayan, binaubo na. Okay. So the underlying cause should be addressed to prevent recurrence. Yes, dietary supplement, you have there the milk, no, pero class dilin ani ang kuan na. Huwag nyo tularan itong nasa picture, no, nagyaga-yaga ranin sila, no? Wala siguro ni abot asa na lang utok ana, no, ginayabo jud nila ilang milk. Basid ay kuan may mag-drink anak lain, no. Okay, you have there the milk, cheese, and cereal, and you also have there your oral IV calcium, yung ating calcium gluconate. This is the most common talaga, class. This is the most common solution for your calcium solution. You also have there your vitamin D supplements. You also have there vitamin D supplements, no, para to facilitate the absorption of your calcium. Ayan. So you have here the management as well. Same lang gyapon sa akong giingon sa taas. Okay, so this is where you're going to. Ayan, watch out for bleeding. Check for the apical for the arrhythmias, and an IV infusion of your calcium gluconate. Check gyapon. No, monitored gyapon nato ng iyahang ECG or yung cardiac monitor nato. Same na. No, here and here pareho na sila ang content. Okay, hypercalcemia naman tayo. You have there your hyperparathyroidism. Kung doon sa kabila, your hypoparathyroidism. Dito naman ang pinaka-cause dito natin is hyperparathyroidism. Remember that your parathyroid hormone increases, right? It addresses the low calcium levels. So continuous stimulation, continuous secretion of your parathyroid hormone, tataas talaga yung ating abnormally high talaga, magiging abnormally high yung ating calcium levels. Okay? You also have their metastatic malignancy. So there will be yung mga osteosarcoma natin. So bone destruction, increase ang bone destruction. So lalabas yan sila papunta sa inyong bloodstream. Kaya tataas yung ating anong tawag ito? Blood calcium levels in the blood. I'm sorry. Okay, and you also have your thiazide diuretics, potentiates the pTH and decreased excretion on your kidneys. So there will be increased retention of your calcium, increased vitamin D naman natin, of course, hypercalcemia. Increased vitamin D meaning increase ang calcium absorption sa ating intestine. And of course, you also have there your prolonged immobility. No, musaka gyapon na imuhang calcium levels dira. So you have here your nursing management for your hypercalcemia. Okay, too much calcium. Okay, so mas mataas or more than 11 milligrams per DL. That is already too much. Now, it can be the outcome of your hyperparaon. Nasabi na ito kanina. Yes, check. Bone metastasis, yes, check. Calcium resorption from the breast, the lung, or multiple myeloma. Okay. So you have there loss of excitability. That means that, diba, inversely proportional. Pag mataas sa ating calcium levels, mababa yung ating impulse transmission. That's why you have their fatigue. You will be feeling fatigue, weakness. Kasi remember, your calcium is also important in the contraction of muscles natin. Kailangan ng calcium talaga when your muscles contract. May it be your skeletal muscle or may it be your smooth muscle, which is located doon sa ating blood vessels and even in our, ano tawag ito intestines natin, and even in your cardiac muscle. Okay, so those are the three types of muscle tissues that is being affected by your hypercalcemia. So you have there your lethargy, anorexia, nausea, constipation, and kidney stones from increased calcium salts. So magkakaroon pa tayo ng problema na kidney salts. This is what we call your calcium oxalate. Now, I will be discussing this one in your renal calculi. No, calculi means stones. No, marami tayong types of stones doon. So I'll be discussing your calcium oxalate. So ECG naman, check naman ECG natin. So you have their shortened QT segments and depressed T waves as well. And bradycardia and varying degrees of heart block. Kasi nga, decrease ang impulse transmission. So ayan, bradycardia tayo dyan. Okay, medical management. You have there your calcitonin, okay, or your calcitonin, okay? Because remember yung calcitonin natin, it addresses hypercalcemia para maging magbaba yung ating calcium. Okay? Now remember, yung calcitonin, anong nag-secrete na gland? It is your thyroid gland. Okay? You also have there your biphosphonates. Sir, tanong, ano tong biphosphonate? Remember, if we're going, di ba, nasabi ko na sa inyo that your sodium and your potassium, they are inversely proportional. Kung mataas ito, mababa ito. Okay, and vice versa. Dito naman, phosphate and your calcium, they are inversely proportional. Okay, pag mataas ito, okay, mababa ang phosphate. Kaya binibigyan mo yan siya ng biphosphate for your calcium to lower down. Kuha natin, ayan. Now, if there is an increase in activity of the PTH, there is a risk for fracture kasi nga PTH, osteoclast activity. And remember, pag sinasabi natin osteoclast, these are bone-destroying cells. So there will be demineralization of your bones, no, para mag-escape doon, kaya nagkakaroon ng brittle. Magiging brittle yung bones ninyo. Okay? So magkakaroon ng fracture. Okay, what are we going to give? Fosamax. Okay, that is your medical management for your risk for fracture or yung hyper natin. So this will now inhibit the osteoclast activity as being done by your PTH. So if ever you're going to give Fosamax, place the patient in aspiration precaution. Bakit? Because your Fosamax is an esophageal or it causes esophageal irritation. Maiirita yung ating esophagus niyan. Okay? So what are the nursing interventions? Okay. So after giving or prior to giving your Fosamax, mukaon man ang patient mo. So elevate head of the bed of the patient during eating and after eating. Okay? And then NPO tayo for 30 minutes after eating. Same here as well. After eating mo, wait ka rin ng 30 minutes before mo i-lower yung kanyang head of the bed. So this is what we call, anong position ito pag the head of the bed is elevated? Ano position?
Fowlers po.
Very good. This is your Fowlers. Okay? High Fowlers during eating. Okay? And then pwede tayo mag-semi-Fowlers after. Okay? Basta Fowlers gihapon. Ayaw na ninyo i-flat on bed. Okay? Ayaw na ninyo i-supine. And of course, we have there your loop diuretics for increased excretion of calcium. Ayan. Okay, nursing management, be sure to monitor your calcium levels, serum levels tayo, serum electrolyte levels tayo dito, serum electrolyte levels. Okay, at risk for hypercalcemia. Such as those who have cancer, parathyroid disorders, no, are immobile kasi risk factors na ito eh. Okay, or receiving calcium supplements para malaman natin kaagad if ever there are any calcium imbalance already. No, specifically your hypercalcemia. For a patient who develops hypercalcemia, you take the following actions. Monitor VS, yes, no, yung BP natin kasi in hypercalcemia, you have there what? Hypercalcemia, low impulse transmission, check for hypotension, ayan. Okay, yung mga irregularities natin sa pagbeating ng heart natin, bradycardia, okay. Watch patient for arrhythmias. Aside for that one, no, expect kasi hypercalcemia, decrease RR. Remember, respiratory spasms, bronchospasms tayo dito. Okay? Kung hindi man mag-decrease ang respiratory rate, check if there is or there are any stridor. Okay? That means that there is already bronchospasm. Okay? Auscultate natin yan siya. BP natin dyan, decrease ang BP natin. Okay? Cardiac rate, most of the time, or pulse rate, bababa rin yan siya. Okay? Dito sa ating respiratory rate, you have there your stridor and your bronchospasms. Ha? Auscultate natin. Kung hindi, bababa yung respiratory rate. Ayan, watch for ECG to monitor arrhythmias, calcium levels monitoring, serum, electrolytes, encourage mobilization kasi kung immobile ka, it will lead to hypercalcemia and dietary limits of your vitamin D or calcium. Last topic for tonight. Okay, magnesium tayo. Ay, magnesium natin, and impulse transmission are inversely proportional. Same with your ano tawag ito? Calcium. Let's recall your magnesium sulfate, yung magso natin. Okay? What is PIH? Anong meaning ng PIH?
Pregnancy-induced hypertension.
Yes, exactly. Pregnancy-induced hypertension. Or this is what we call your toxemia of pregnancy. Di ba? Ang binibigay natin dito, drug of choice natin, magso. Magnesium sulfate or yung ating kinakuha na nila. Magso. Ano. Okay, pero ito mo din siya ang kuha na magnesium sulfate. Okay? Now remember class, if you could still remember yung inyong OB or yung DR ninyo na rotation, pregnancy-induced hypertension, you're trying to prevent yung ating eclampsia. Diba? You have your pre-eclampsia and your eclampsia. Sa eclampsia natin, there's seizure already. Sa pre-eclampsia, both of them has hypertension or presents hypertension. Yung ating eclampsia lang is just that nagkakaroon ng seizure. Okay, yung ating patient. Kuha natin. So this will now prevent seizure or convulsion, no? Para hanggang doon lang siya sa pre-eclampsia, and at the same time ibaba nato or ginapagamian nato ang ilahang blood pressure. Okay? Kaya ang PIH nato, taas yun lang blood pressure eh. Okay? Tapos napagano siya panghupong. Basta ang panghupong nato, edema on the face and the upper extremities, that is a danger sign. Danger sign of your PIH. Tapos kung sa ating lower extremities, normal lang na. Okay? You watch out for edema of the upper extremities and of the face. No? Okay, that is pre-eclampsia na siya. Pag once mag-seizure na siya, eclampsia na siya. Okay? So magso na yan siya. If you could still remember class, before ka maghatag og magso, unsa itong buhaton for the patient?
Check sa reflexes the tendon, sir.
Yes, exactly. Correct, Ms. Ron. Deep tendon reflex, DTR. Deep tendon reflex, patella reflex. Same lang na sila. Another term for patellar reflex. Same lang na sila. And unsa pa? You have there your knee jerk reflex. Okay? Same lang na sila tanan. DTR, patellar reflex, knee jerk reflex. Those are just the same reflexes. Musipa na siya. So you're going to use your reflex hammer. Bunalan nimo imuhang ang ilahang kuan patella. Okay, kung sa ni banda. Okay, hypomagnesemia na tayo. Inversely proportional impulse transmission. Ito yung mga manifestation natin. Okay, seizure or convulsion. Yes, hypo tayo, hypo. Okay. You also have there your ventricular dysrhythmias. Ito yung mga dysrhythmia natin. You have there two types of dysrhythmias. You have there your VTAC or your ventricular tachycardia. Sa akong ganit may pagbasa. Torsade de poids. This is a French word. Torsade de poids. Everybody say torsade de poids. Yun na. Kapit na kita mahuman.
Torsade po.
Torsade po.
Torsade.
Very good. Sige. Very good kayo nang nagakuan. Participate. Salamat, Jude, no, for keeping me going. Ana, this is your polymorphic type of ventricular dysrhythmias. Ito lang, for your VTAC or your ventricular tachycardia, meron tayong ginagawa dyan for the patient. No? It's what we call your Valsalva maneuver. Sir, sa ganin ng Valsalva maneuver? Ano man na?
Kanang murag magsikma, sir.
Magsikma? Yes. No, pwede kasi may force yan. Pwede. Okay? That means that you are trying to exert force kanang if you are bearing down, no? Kanang mag-bear down ka, that is basically your Valsalva maneuver. Kanang mag-utong. Maglibang ka, Valsalva maneuver. That's what you're going to do, Valsalva maneuver. Okay? Mag-utong ka, malibang, Valsalva maneuver. Magsikma ka, Valsalva maneuver. Okay? Ang Valsalva maneuver natin, hindi yan natin ginagawa pag meron tayong may stroke. Kasi it decreases man. Ano pala ang kuan ito? Ano pala ang action or what is the effect of your Valsalva maneuver? It decreases your heart rate. Okay? Decrease niya yung heart rate. That is why class, no? Kung gusto niyo i-try, kung gusto niyo lang i-try. Okay? I-check ninyo inyong apical pulse or your cardiac rate. Check niyo yan for 1 full minute. Okay, tapos i-write niyo yan. And then you're going to do Valsalva maneuver. Kanang itong more forceful breathing. Kanang mag-breathe ka at the same time you are trying to exert effort. Kanang itong malibang. You do it for like 5 minutes or maybe 3 minutes. Basta malipong. Kanang ma-feel niyo nga malipong na mo class, kana nag-take effect na because i-check din ninyo ang inyong heart rate because mubaba, munaog yun ang inyong heart rate ana. That's what they do for your dysrhythmia. Natay kuan ana viral nga video sa Facebook wherein give Valsalva maneuver. Klaro kayong VTAC sa kuan sa ECG monitor tapos after Valsalva, yun normalize na. Okay, nibaba po ng iyang heart rate wherein that was like 140 ang heart rate tapos naging 80 na lang, 80 to 90. No, perfect pagka kuan. pagka-execute. No, management, magso, drug of choice for your PIH or toxemia of pregnancy. Nursing responsibilities when administering magso, check for drop. Okay? Remember, hypomagnesemia inversely proportional to your impulse transmission. Okay. Now, meron tayong tinatawag na drop. D is for what? Check for deep tendon reflex. Okay. Next. Okay. Check for respiratory rate. Okay. Next, check for output, urine output, oliguria. Okay. And lastly, P is for your blood pressure. Check for pressure. Okay. Now remember class, in your hypomagnesemia, inversely proportional na siya. Inversely proportional. Okay. Ano yung mga manifestations natin? Drop pa rin tayo. Okay. What do you think if magnesemia siya? Do you think ang ating deep tendon reflex or DTR? Anong ating DTR? Positive, negative?
Positive.
Pag hypomagnesemia. Ano siya ba? Okay. For your deep...
Positive, sir.
Yes, exactly. Okay. Positive na siya. Okay. Next, respiratory rate natin. Mataas, mababa? Mataas, mababa, respiratory rate natin.
Taas, sir.
Yes, exactly. Mataas. Very good. Okay. Output natin. How about for your urine output? Mataas. BP? Mataas. Kaya nga binibigyan natin ng magso eh. That's why you are giving the patient magnesium sulfate. And you have to check on this one. Ito yung mga manifestations natin ng hypomagnesemia. Okay? Positive deep tendon reflex natin, increase RR, increase yung ating urinary output, and you also have there your increase ating blood pressure. Kuha natin. That is why binibigay natin yung ating magso sa patients na merong PIH sa ating DR or sa OB natin. O DR pala, I'm sorry, DR wala pa din nanganak PIH pagani. Okay? So ayan. Dito naman ang ating manifestation sa ating hypermagnesemia. This is the last slide already. Okay? Ano tawag dito? Pag meron tayong magnesium toxicity, this is what we're going to watch out for, no? Yung magnesium toxicity natin. Okay? So you have there, deep tendon reflex is absent. Okay? Respirations natin, mababa yung respirations natin. Output natin, oliguria. Okay? Doon sa kabila, polyuria. Pwede natin ilagay doon, polyuria. O, sige, ilagay natin polyuria. Okay? Polyuria. Okay? Dito naman, pressure natin is mababa, hypotension. These are manifestations of magnesium toxicity. Kuha natin. Okay? So decrease impulse transmission, these are the manifestations already. Now, sir, tanong, ano yung pinaka or which among the four is yung early sign of magnesium toxicity? Which among the sign will tell you? Saan dito? A,
DTR, sir.
C. Yes, exactly. It is your A. This is the earliest sign of your magnesium toxicity. Mauna class, kita ka, hala, wala ni sipa ang patient pag ana nimo sa imuang reflex hammer. Gihatagan pa jud nimo og magso. Patay ka dyan. Patay kang bata ka. Okay? Ayan. Ayaw na siya hatagi because that means that toxic na kaayo iyang or taas na kaayo ang iyang level. Yes, tama kami sa Aranyas, no? DTR. Okay? Muna siyang early. Okay? So these are the signs of your magnesium toxicity class. Okay? Etiology of your hypermagnesemia or what is the cause, bakit tumataas yung ating magnesium level is because of your renal failure. We will be discussing this one thoroughly. No? Pero these are the effects of your renal failure. Decrease ang excretory function niya. That means that there will be decreased excretion of water. That is why you have here taas ang imong blood volume. Decrease electrolytes level, that is why naakaani. Okay? Naakaani nga problema. Increase or decrease excretion of waste. Okay, that is why there is a buildup of your CREA and your BUN. And if you can still remember, your CREA and your BUN, these are your liver function tests. Mosaka na sila if you are experiencing renal failure, either acute renal failure or chronic renal failure. Pareho sa nasa mosaka gyapon na. So for your effects, no, you have the increased potassium, increased phosphate as well. Okay? And if there is increase in phosphate, di ba sabi ko sa inyo kanina, inversely proportional yan siya, bababa yung ating calcium levels. Okay? There will be a decrease in your pH as well. Pag decrease ang pH natin, acidosis yan siya. Okay? And since we're talking about renal failure, metabolic, kasi may problema tayo sa kidney. Okay? Due to the excretion of hydrogen and or decreased excretion of hydrogen and mataas yung ating magnesium levels. Okay? Medical management, yung antidote talaga natin sa ating toxicity, sa ating hypermagnesemia, calcium. It is your calcium gluconate. Mauna siya ang inyuhang antidote class ha. Antidote. Okay? For your hypermagnesemia. O ito, last question before we end. Good. Let's say, for example, you have a patient with hypermagnesemia and develops PUD or your peptic ulcer disease. And you need to administer antacids. Now, which of the following antacids will you expect to be ordered by the physician? Kani siya, aluminum hydroxide ni siya. Okay, this one is magnesium. I don't know if this is magnesium chloride or magnesium hydroxide. Magnesium chloride. And your Maalox, that is basically a combination of your A and B. O, sige, asa dire. Meron ako yung hint.
A, sir.
So meron nag-answer C, may nag-answer C, may nag-answer A. Sino nag-answer ng A? May answer A then A, C, tapos may C. Guys, remember, hypermagnesemia. Hyper. Problema na to, taas ang atong magnesium. Mooni ang content or this is the other name for your magnesia and Maalox. Okay? Saan dito ang walang magnesium? It's of course your amphogen. It's just aluminum hydroxide. So your B is wrong, your C is wrong because both of them contains your magnesium. Okay? Pack. BBC, no? Itim lahat ang nakikita ko. Okay. So the answer there is A, ha? A. Ayan. Okay? So are there any questions, 'di ba? Ano yung kasabihan natin? Once you go black, sumpayin
Can
ninyo.
never go back.
Oh, sweet. Sweet. Okay, you can never go back, no? Punit. Ayan. Punit talaga. So tomorrow, quiz tayo on your acid-base balance and a little bit of the reading of your ABG. No, mga siguro 8 items for the reading, or maybe 5 items for the reading of your ABG, and then the other items would be coming from your acid-base balance imbalances. Kuha. Ayan. And then of course, Wednesday, asynchronous tayo. Alam mo ano sa inyong life, no? Asynchronous tayo sa Wednesday, sa 4 to 6. Pagkaugma, kasi may tabos yung pagkaugma. Diba namoy?
Mental health break.
Mental health. Gi-release na di ay. Ayan. Diba? So, kuan class. Ayus-ayusin yung buhay ninyo sa Thursday, no? BBC. Watch BBC. Kanang news, ha? Ayaw tong BBC nga. Okay, para ma-check na tong mga COVID na to ba? Okay? Ayan, sige, pray na tayo. Pray na. Miss Arangkon, ikaw man to nang ingon nga, there's no going back daw, there's no turning back, or there's no returning back. O sige, let's pray. Miss Arangkon, lead the prayer.
Yeah. In the name of the Father, the Son, and the Holy Spirit, amen. Glory be to the Father, and to the Son, and to the Holy Spirit, was in the beginning, is now, and ever shall be, without end. Thank you. Thank you, sir.
Okay, sige. Ay, wait lang, may question. Hello, sir. Kanina na dapat na question. Pero may difference ba ang enema with barium enema? Both of them are being kwan. Meron. Yung barium enema ninyo and with the enema using the kayexalate, no? Ang enema is a general term for administering doon sa ating puwet, no? Of a solution or whatever solution. Ang barium enema, it is more specific. The solution there that they're going to use is barium. Okay, kuha natin. So, meron din tayong soapsud enema, mga ganyan. So, pero same lang yapon na siyang route. Okay? Yung kayexalate natin na enema, of course, the solution that we are using there is yung kayexalate. Yung gina-introduce nato sa lubot sa pasyente para mag exchange yung resin natin. Sodium and potassium sa ating intestines. Okay? Ayan. Nangalago na daw sila. Wala pa nagbabay. Oh, sige na. Okay lang. No? Kuan ba? One day dapat mura mo mga Nigerian, no? Para Sir, tanong, question. Sir, repeat. Okay? O, sige na. Bye-bye na, bye-bye. God bless, and see you tomorrow.
Bye-bye, sir.
Thank you,
po,
sir.
sir.
Mga ambag sa buhay. Thank you, sir. Sige, bye-bye.